GI tract disorders. This is basically, there aren't that many, so we're going to start with this one because I think we can get it done before lunch and let you go to lunch at 11:30 by the latest. So if you want to order food ahead for pickup, 11:30 would be a good time. We are going to do like just a half an hour for lunch because I do want to just kind of get through it and let you go home. But the normal digestive process, this is, again, your information to put in your heart and understand the pathophysiology, but I don't physically test you on the patho behind it. Really, it's a tube. It's a tube that's a muscle. It is a muscle. It is a smooth muscle. So it does not work like skeletal muscle. It's a little bit different, but from your mouth all the way down to your butt is a continuous smooth muscle. It uses peristalsis or muscle contractions to move everything along. So your esophagus is a muscle, your stomach is a muscle, and all of your intestines are muscles. So they do work like muscles, and they do respond to a stimulus. The stimulus is the vagus nerve. The vagus nerve is the one that controls your rest and digest process. So when you stimulate your vagal system, which is your parasympathetic system, you are encouraging peristalsis. You're also encouraging waste removal. Your kidneys and your bladder also respond to the vagus nerve and kind of pump up their production. They know that you're not stressed, you don't have any flight fright going on, and you are comfortable, calm, and relaxed enough to digest. Your heart rate kind of slows down. Your blood flow shunts to the gut, and your breathing slows down. Most of your metabolic activity is focused on the gut, and the vagus nerve, the parasympathetic system, controls that. So when your food enters your mouth, you may know this. Did you have to take anatomy and physiology? Yeah. Yes. So this is why there's only one or two slides. I just want to kind of remind you of what you learned in anatomy and physiology. When the food hits your esophagus, you chew it up and you masticate it because you chew 20 times or 40 times like your mom taught you to chew up your food. The reason being, let saliva get in there and start breaking down complex foods. You don't have to chew as well for a carb or liquids, but for like a steak or something heavy or high protein, we usually try to chew that up because proteins and fats are hard to digest. Proteins and fats are very hard for the GI system. Carbs are very easy for the GI system. So if we're going to eat a lot of fats or proteins, chewing better is better because that starts, the saliva has acid in it, and that starts breaking it down before it gets in there. Once food hits the esophagus, the vagus nerve is stimulated. So as food moves down that esophagus, it only takes like 3 to 8 seconds to get from your mouth to your stomach. But during those 3 to 8 seconds, as that esophagus starts contracting and moving food down, your vagus nerve becomes stimulated, and that will slow down your heart rate. It speeds up your peristalsis and your waste production. It signals out to the kidney, to the liver, to the stomach, to the intestines. It's about to go down. We got to digest. Which is why they always tell you you're going to get stomach cramps if you go swimming too soon after eating. It's an old wives' tale, but it is based in truth and reality of the fact that your body has geared down to digest. It's a heavy workload. And if you're digesting and then you go do something stimulating, then the body's like, what? I'm digesting here. What are you doing? And so sometimes it gives people a little bit of people who are sensitive to what's going on internally, they're getting mixed signals. You're sending your body signals, hurry up, I got to do something stressful, like swim a lap or two. Now, splashing around the pool is not the same thing, but if you're going to go swim 18 laps after eating, or if you're going to eat a big meal and you go out and you take your 4-mile jog, you're sending mixed signals to your body. Your body's like, I just ramped down so that I can focus on the gut. And now you're, oh, for goodness sakes. So some people's bodies are a little more sensitive to that mixed signal, but when your body's like, I'm running, you're sending signals like, I gotta have a heart rate, I gotta do more. And your body's like, but this one told me to slow down. It's like having two instructors. They're telling you different things. It makes you stressed, right? Yeah. And so that's what your body, that's what's happening normally. when your food hits your esophagus is that parasympathetic system is kicking in, and then if you stimulate your sympathetic system while you're digesting, the body gets a little confused and discombobulated. It can do it, but it's just like stupid. So that's where that old wives' tale came from, based in some fact, because you're doing sympathetic and parasympathetic stuff. The esophageal nerves do have nerves, but they are shared in the same tract as the heart. So if your heart is having pain, it's the same pain. So if you get a chip stuck in your esophagus, I'm sure everyone's gotten a chip stuck in their esophagus at some point in their life. It hurts like nobody's business. You actually start panicking, and your heart rate goes up, and you're like, I'm going to die. And it's not your esophagus doing it. It's because the signals are getting mixed up. The heart shares the same nerve tract. So when something gets stuck in your throat, your body goes into panic mode because it thinks something's wrong with the heart. Even though it's like, I know there's a chip, your brain's like, it's a chip. It's gonna be okay. You just scratched your esophagus. And the body's like, it's not okay. We're dying. I gotta get this chip out of here. And you go into a panic mode. It's because we share with the heart. It's also why heartburn and indigestion feel like chest pain. So I just think knowing all those little background things are very helpful. The esophageal sphincter is at the bottom of the esophagus. It's also called the lower esophageal sphincter, but there's only one esophageal sphincter, so I don't feel like we need to call it lower as well. It's just there at the bottom of the esophagus to keep acid in the stomach, because the esophagus is not lined with anything to protect it from acid. So we don't want acid in the esophagus. The only acid the esophagus gets exposed to is your saliva, and that's not as acidic as your stomach. So the vagus nerve also is in charge of opening that sphincter, because it's like, dude, it's going down. Open it up. So the vagus nerve is in charge of opening that sphincter. So if your vagus nerve is not working properly, you might have some issues with that sphincter opening and allowing food into your stomach. The gastric cells, making not all of your digestive system. The pancreas makes the rest of them, but it does make 3 most acidic enzymes are in the stomach. Hydrochloric acid, which is a literal acid. Pepsin and gastrin are going to be lytic. If you ever see the word lytic, it means break down. And so if the pepsin and gastrin start breaking down the complex substances. So the hydrochloric acid is in there to turn everything into mush. If you put a piece of steak in hydrochloric acid, it's going to turn into blended steak pretty quickly. And that's what's happening in your stomach. Pepsin and gastrin are also there to start the process of breaking down proteins and complex fatty acids. The stomach protects itself from this acid that it is secreting by secreting bicarb to itself. So those gastric stomach muscles, all the gastric stomach cells, can make acid and can make bicarb because it's trying to protect itself. So it's coating itself with mucus so that it won't die in an acidic environment, because all of our cells in our body, they live to a pH of 735, 745. What do you think the pH is in the stomach? It's like 3. That will kill a body cell like that. So that's what the bicarbonate-rich mucus is so that all the acid that hits the stomach gets neutralized before it even hits the cell. Complex foods can spend 2 to 4 hours in the stomach. Liquids pass through pretty quickly, but complex foods stay there until they are the consistency to pass out through the pyloric sphincter, which is at the bottom of the stomach. So you have the esophageal sphincter up there, and then the pyloric sphincter down there. It stays in an open state and just kind of lets things move from the stomach. So if you just drink some water, that water will just kind of move straight through your stomach and into the intestine. Anything liquid will move straight through the stomach and into the intestine. And then as the mush gets mushed up, it moves straight through until that duodenum, which is the first piece of intestine right after the stomach here. When that starts getting full and disgorged, it slams that sphincter shut. Like, we can't handle anymore. Shut the sphincter. You keep that stuff in there until we've processed. And once everything moves out of the duodenum, then it opens up and things move through again until it fills up and then it shuts. And so it's slowly gate releasing stuff out of the stomach. So there's that upper. Then we go to the we go to the intestines. There are 3 pieces of the small intestine, duodenum, jejunum, and ileum. They are all there to absorb nutrients. The one thing I want to point out about the duodenum is the pancreas and the bile. Well, we don't have a picture. You'll see it when we do the liver. The pancreas and the liver dump into all the remaining digestive enzymes, and bile will get into the GI system up in the duodenum. That's where the inlet from the pancreas and the liver is. So basically you get the first 3 in the stomach, it moves into the duodenum, we add a couple of more breakdown enzymes in, and then it continues through the intestine. And all of it absorbs nutrients. The ileum does specifically do vitamin B12. It doesn't do anything. B12 is going to be special when we talk about that in hematology. So you'll get that back in hematology. Then the large intestine there are 4 parts of it, and it just describes how it moves. The small intestine's huge. They're all crumbled up in there. But the large intestine, we have the ascending, transverse, descending, and the rectum. So that's basically our whole tract. This is just your diet. I usually try to give you some labs here, some diagnostic testing. The point for endoscopy, and we do have a whole thing on care of the patient after endoscopy, care of the patient after colonoscopy. I have care of the patient after upper GI surgery, and care of the patient after intestinal surgery. So we do have 4 procedures that these patients can go through. They can also, so endoscopy, colonoscopy is where we actually shove a camera in somewhere. Endoscopy, it's going through the mouth, down through the tract. Colonoscopy, going from the bottom through the tract. There is a dead space or a blind spot. Endoscopy can see to the top of the duodenum. So endoscopy can get all the way to where the pancreatic and liver feed into the duodenum, but after that we run out of camera, right? We're just there's no more room. The camera's only so long, but it gets all the way into the duodenum, and that's it. The colonoscopy only does large intestine. The colonoscopy, that camera gets up into the end of the large intestine, but then it runs out of room. So there is no way to see your small intestine past the duodenum with a camera. So to get into the small intestine, then they need either the X-ray or the CT or the MRI. And you've learned about contrast, right? Kind of, yes, no? What have you learned about contrast? There you go. That's pretty much the only thing to do. And what are you allergic to that you can't have contrast? Shellfish and iodine, yes. Shellfish, iodine, you cannot have contrast because contrast has iodine in it. The reason we use contrast is if we took a CT scan or an MRI, it would all just look like blobs of junk. And X-rays are not very specific. You can kind of see distension, but you can't see many details. Contrast coats the intestine lining and allows it to show up in sharper image. It's kind of like putting a developer in there so that you can really see the areas and the walls of the intestine because it kind of coats the walls. And so contrast is needed to get a good image. If they have to do it without contrast, they'll tell you the image won't be that good. It's kind of like endoscopy, colonoscopy. When we go through the care of them, you'll see you get prepped for those, right? Have you had a colonoscopy, anyone? If you haven't, you'll get prepped for it because they cannot use that camera to see anything if it's full of crap. So you get squeaky clean before you get your camera in there. Contrast kind of does the same thing. Yeah, we can't really squeaky clean it. You'll still get a prep, but that prep has contrast in it. So as you get squeaky cleaned, you are actually then depositing the contrast on the wall of the intestine so you can get a better picture. They will do these images, the CT and the MRI, without contrast, but they won't be as informative or detailed. So if your patient's like, I don't know why I have to drink this stuff, you can say, you should drink it because otherwise you're just going to have the test done again, or you're not going to get really good answers. And if you want good answers, do the contrast. I mean, you can fight with me all you want because contrast is nasty. It tastes disgusting. I don't know if you've ever had people come up in clinical where they have to get the big bottle of contrast to drink, and they have to drink it. IV contrast doesn't get into the walls and coat the walls for that good picture. So most patients getting contrast need to drink it. And it's disgusting. Even if you put it in water with ice and you put something in it, it's gross and they don't want to drink it. And I'm like, you got to drink it if you want this exam to mean anything to you. I mean, it's your exam. Do it or not. But that's why contrast is there. Then they also have developed a little micro camera that you just swallow this pill with a camera in it. It travels through your intestine and goes click, click, kind of like, what is that show? Magic School Bus? It's like a little camera, goes through, clicks pictures as it moves through the intestine, and you poop it out, but the pictures are transmitted via Bluetooth to your doc, which is kind of cool.
I had that. Well, I had
Did
all
you?
those things done, but you have their cameras. It's like you can look at it.
Oh, you can look at it as it goes
It's got
through?
a little screen on it. You can check it like as we're.
Whoa, that's pretty cool. I didn't know that. Cool, thanks. Camera, you can see it.
Yeah, like the little thing. It's not like live action, like if you turn it on, because it just takes pictures.
Uh-huh.
It's not a recorded image. So it like, takes a picture.
It's kind of like a satellite sending pictures back to Earth.
Yeah.
Did
so
you
can
contrast
picture-
beforehand, or did you do
not
anything?
for that.
No prep?
No. Well,
Okay.
for the colonoscopy and endoscopy, there are prep stuff, but not contrast.
Not for the, well, not contrast, but also did you have to have a squeaky clean intestine before they sent the camera down? I'm just curious. I haven't.
Fast for 12 hours.
Okay.
First, because.
And you're allowed to drink water to clear it out? Or?
Yeah, lots of water.
So anyway, that micro camera, I'd heard about it, but I hadn't had actually any patients or anything that had it. So that's pretty cool.
Yeah.
So that's how we see the intestine. That's really the only ways we can see the intestine. We can shove a camera either way, but then for that blind spot, we use a CT or an MRI. All right, so let's talk about our upper GI disorders. All four of these, Gerd, hiatal hernia, Barrett's esophagus, esophageal cancer, they all go together. So you can make one guide for these, okay? They all go together. The treatments are all the same pretty much. And then we have ulcers, which the treatments all go together on that. So when I clean this up, it's a little bit, hopefully a little bit better. So I put all first four of them there to tell you what they are. The first one is Gerd, reflux disease. We've probably all heard of reflux disease. This is where our esophageal sphincter is not closing appropriately. And when we eat a big meal, acid comes up into our stomach. And when acid comes up into our stomach, what does it do to our esophagus? It burns it. It's acid. It's acid. It is burning the esophageal wall. The esophageal wall does not have that bicarbonate mucus to protect itself, and so we're putting a pH of 2 or 3 into the esophagus. It's like, oh, I don't have bicarb. I'm dying. And so the pain of Gerd is you're actually burning your lower esophagus. So pay attention to it and listen to the cues that it's telling you. But that is Gerd, essentially, is a dysfunction of this lower esophageal sphincter allowing acid back up. On some patients, it only happens, or some people, it only happens after a really large meal when you've over-distended your stomach. And so because there's so much pressure in your stomach, the pyloric sphincter is like, I can't send anything out. The duodenum said no. You've got this huge ballooned out stomach that's giant, and if it can't get down into the intestine, it's going to blurt back up. And that esophageal sphincter just kind of opens back up, and it's like, sorry, I tried to hold it, but it's just too full. So this is why smaller meals are very helpful in Gerd. If you over-distend your stomach, that sphincter will fail because it's just too full. So that is, you can have Gerd occasionally from an over-distended stomach. I wouldn't get too worried about it. But if it's happening all the time, or when you're sleeping, or a couple hours after you ate, when food should be out of your stomach, then you have a problem with the sphincter. This could be happening for a while, and you could just burn that sphincter up. If it just gets too damaged, that sphincter starts to get damaged, and then it doesn't close all the way, and food gets into your stomach. Or stomach gets up into your esophagus. Hiatal hernia is the picture over here, where you physically have stomach wall bulging up through your diaphragm. This right here, in case you're not reading the sides here, this is your diaphragm. Your diaphragm is a muscle, and it separates your thoracic cavity from your abdominal cavity. But the only thing that can get through the diaphragm is the esophagus. That's it. Otherwise, it's a solid muscle. But there is a hole in that muscle to allow the esophagus through. And if that diaphragm hole gets too big, or if the stomach gets pressurized way too much, then it goes poop up through that hole, and the stomach actually herniates into the thoracic area. Now, it doesn't damage the stomach. It just kind of is it's a protrusion. It's just the stomach is actually fine, but what it does is it messes up the functionality of the esophageal sphincter. It kind of relies on the diaphragm to hold it closed. And when you bulge up the stomach, the esophageal sphincter doesn't work as much. So a hiatal hernia will give you the same symptoms as esophageal of Gerd, but it's just a different reason for it. Barrett's esophagus and esophageal cancer happen if you let these things go too long. Barrett's esophagus is precancerous, and esophageal cancer is cancerous. So most patients will develop Barrett's esophagus before developing esophageal cancer. But the symptoms aren't very different from Gerd either. So you don't really, the only way to see it is to actually scope it and look at the changes in the wall. So what we expect for when I say esophageal disorders, I am talking about Gerd, hiatal hernia, Barrett's esophagus, and esophageal cancer are all in these cues. And you can see that I put Barrett's esophagus and esophageal cancer as the worsening conditions of Gerd or hiatal hernia, because they don't happen unless you don't treat your Gerd or hiatal hernia. So your cues that you have Gerd, you probably all had it: heartburn, belching. This is belching after your meal, or you have those little verps, you know. Heartburn, belching, chronic cough, frequent hiccups. If you're having frequent hiccups after meals, that is probably a sign that you have a hiatal hernia. Because what is that doing? Why are you getting hiccups? Any ideas?
Isn't it like the diaphragm spasming?
Yes, a hiccup is a diaphragm spasm. That's all a hiccup is a muscle spasm of your diaphragm. If you have bulged up stomach through there, now this diaphragm is more easily irritated, and when your stomach is full and food might be kind of stuck up there and everything, you're irritating the diaphragm, and that causes hiccups. That's why they tell you to hold your breath when you have hiccups, because you're keeping the diaphragm still, or you're making the diaphragm work to hold it in place. And so it's kind of like if you get a Charlie horse, you just kind of hold your leg or you stretch it and try to stretch out your cramp. That's what you're doing, because your diaphragm, when it hiccups, it's a diaphragm spasm. So hiatal hernia, that's if you're getting frequent hiccups all the time, you might want to tell your doctor, because it could be a sign of hiatal hernia. Mild chest pain improves when the stomach is empty, and this is because the esophagus is saying, I'm being burned. Sometimes it feels like it's being burned, but sometimes it feels like chest pain because that heart and that esophagus are sharing a nerve. And so it feels like chest pain. And patients usually go in with chest pain and they say, wow, your EKG looks good. Wow, you don't have any cardiac enzyme problems. You bet you have heartburn. And they kind of tell you have heartburn and they treat you for heartburn. So not many symptoms, and you've probably all experienced them. They get called Gerd or hiatal hernia. Gerd is usually if it's happening with every meal, or when you haven't eaten. That's how you get the diagnosis of Gerd, is that it is happening every time you eat, or when you're not eating, you're getting Gerd symptoms. Just having it occasionally, when you overeat, don't worry about it. It's because you overate. Maybe slow down your eating or eat smaller meals or something like that. But it's understandable after Thanksgiving dinner. You just don't eat your stomach. But hiccups, I would counsel your patient, hey, if you're having those plus Gerd symptoms, maybe go talk to your doctor about it, because they might want to get some diagnostic testing. Worsening cues is basically letting acid burn the esophagus for too long. If acid burns the esophagus repeatedly for a long time, it will erode away the esophageal wall. The worst case is that you erode through the entire esophageal wall. And then the next episode of Gerd, when you have stomach regurgitation, where's that stomach acid going? Out into your thoracic cavity. That is amazingly painful. Very rare. Most people will come in with chest pain before it gets to this point, because if you are eroding through your esophageal wall, you're going to get some signals from your body before you've eroded through to the point where there's a hole in your esophagus. So they will probably be very frequently at the at the ER with chest pain, they will probably have prescriptions or advice to take the medicines for Gerd. But if they are non-compliant with their medications for Gerd, or they're doing other risk factors that damage their esophagus more, then perforation is literally a hole. Bleeding and perforation is a hole in your esophagus, or a hole through a blood vessel surrounding your esophagus. And that's like probably the worst thing that can happen. And what's going to happen is a hole in your esophagus is going to mean that any food you swallow or any reflux is going to go out into your thoracic cavity, because your esophagus is in your thoracic cavity. What else is in your thoracic cavity? Your lungs and your heart. So it's going to hurt. But most patients don't get here because they're seeking treatment in here. Barrett's esophagus and esophageal cancer, this is going to happen before, maybe. It's not like you're going to get cancer before you get a perforation. But we should just be on the lookout for all of these worsening symptoms. You should not have pain when you swallow. The pain when you swallow is similar to having a chip stuck in your throat. That's painful. If they are having that kind of pain every time they swallow, not just swallowing a chip the wrong way or not chewing, if they're having pain every time they swallow, it's called dysphagia. Hoarseness. Why would you be hoarse? Why would you have a tiny horse? What's happening? You've burnt your vocal cords, which means that acid has gotten all the way up your esophagus and started functioning with the epiglottis. That's pretty late if you are having hoarseness. So if you have chronic hoarseness and chronic Gerd, that could be a sign like, no, you really need to see the doctor now, because you're doing way more than just having some reflux. It's refluxing all the way up to your epiglottis, to your vocal cords. Please go see a doctor. Feeling like something is stuck in the throat, that is, again, ulceration of the esophagus. If your esophagus starts ulcering, because if you got reflux up there that's damaging the esophagus, that causes an ulcer in the esophagus. And the ulcer in the esophagus feels like there's something stuck. You're constantly swallowing. You're constantly trying to move through things. You are stimulating that muscle in your esophagus. It's like, I'm hurt. And sometimes it comes across as chest pain. Sometimes it comes across as feeling like something's stuck in the throat. So if you're constantly feeling like that, or your patient's saying, yeah, every time I eat, it gets stuck. And they have some more. It's like, please go see somebody, because you're especially if they're like, yeah, I've had reflux for years. Please go see somebody, because it could be a sign of a worsening condition. Esophageal cancer is a tumor now in the esophagus, not just ulcers and acid going through it. There's actual tumors now, because the cells have tried to clean itself up so many times that it just replicated wrong in one of the cleanup processes, and now you got a tumor. So these tumors do get into your lungs because they're right next to your lungs. And so you can end up with frequent pneumonias from these tumors causing an inflammatory condition. That inflammatory fluid can squeeze into the lungs. So you get frequent pneumonias. They might you got a tumor in there blocking, you're going to vomit up undigested food, because that food never made it to your stomach. So that's a sign that you've got a blockage in your esophagus. Hemoptysis, what does that mean? What are hemoptysis and hematoemesis? Hemoptysis is coughing up blood, and hematoemesis is vomiting up blood. So if a patient's going to come in, they're vomiting up blood, but that is a sign of a worsening condition. That could be erosion through the esophagus, and then you just vomit up that blood. It could be that the tumor is bleeding. You're vomiting up that blood. And if you're coughing up blood, it's because something has infiltrated into your lungs. So that's just one of those kind of cues to be worried about. But you do need to you don't go straight to worsening cues. You need to have your existing cues for years. I mean, your esophagus can take a licking and keep on ticking. But because GI cells, they replicate themselves every 3 days. Did you know that? You get a new GI tract every 3 days, because it's used to being a toxic environment. So those cells replicate really fast. And they do heal themselves. But if you keep abusing it, they eventually stop being able to heal themselves, and that's when tumors kind of build in. So with the most important assessments on these are just asking about their pain and when their pain is. Okay, how bad is your pain? Is the pain worse after eating? Is it there when you're not eating? Where is your pain? When is your pain? That's very important. Ask them about the worsening symptoms. coughing after eating, dysphagia, hoarseness, any bleeding, any vomiting blood, any undigested food if you're vomiting, ask them around that. And test any emesis, even if they vomit just food, check it for blood. Do you know that occult blood just means blood you can't see? So that just means that we're putting some of their vomit, sending it to lab or something so they can dip it and check and see if there's blood in it. Because we might not be able to see the blood, but there is some bleeding going on in the esophagus. We would want to check it. So that's what we're watching. And the treatment is, honestly, just take some acid reducers. That's the treatment for GERD. It's not over complex. But, how hard is it to remember to take all these? Some patients forget, or they just don't, and that's how they end up with this Barrett's esophagus, esophageal cancer. They do some more treatments for it. You don't need to know each treatment, but they are mostly endoscopy procedures, because if something's wrong with your endoscopy, your esophagus, they're going to go in and probably try to do it with the least invasive method, which is a camera. If they do need to do surgery because you have worsening cue, they're not going to really go in and do a scope just on spec. Maybe if you've had GERD for many times and they're suspicious of Barrett's esophagus or esophageal cancer, they'll go in. But surgery is a much bigger option. These are higher risk surgeries whenever we deal with an acidic tube and we cut it open. It is a little bit higher risk surgery. The two big ones are funduplication. It used to be called a Nissen funduplication. I think they just call it a funduplication now. And that means the fundus is the top part of your stomach. And so what we do is we take that top part of the stomach and they will remove the damaged tissue from the esophagus, reconnect the tissue, and then wrap the top of the stomach around it to kind of support. Because if you lose your esophageal sphincter, right? Let's just say you burned it away. There's no more esophageal sphincter. And you've damaged the lower end of your esophagus. And you have Barrett's esophagus. Then they will cut it out. I do have pictures on here. I don't think I highlighted those to you of what Barrett's esophagus looks like. But this is an endoscopy picture down here at the bottom. And the screen is moved. There you go. You will see it on the recording. Healthy esophagus, beautiful, pink, lovely, thank you. Barrett's esophagus just starts, these are precancerous changes. It looks like streaks and striae down there. These are abnormal cells. So you women, if you get a pap smear, that's kind of what they're looking for, is just abnormal cells. Barrett's esophagus just means there are abnormal cells there. They will scrape those and biopsy them to see if any of them are growing anything, like a tumor. But these abnormal cells, they will go in there and they'll burn those cells off and try to get rid of the abnormal cells, because these abnormal reddish areas, they're ulcerations and changes, and they will try to kind of clean up that area before they get to develop into physical tumors that can block the esophagus. So Barrett's esophagus is only really diagnosed or treated through an endoscopy. So if a patient has those symptoms, they're probably going to get an endoscopy. They're not going to go to surgery to diagnose. They go to surgery if they cannot fix anything through here, or if they're already malignant, or if you have a tumor, they need to go in there and lop out the piece of the tube that is tumorous or damaged. So this is the endoscopy ablation. They take something down there and they clean up all that area with Barrett's esophagus. That's just the esophageal procedure. I like pictures. And then, like I said, so you're not going to get into this unless you actually physically have Barrett's esophagus or some kind of cancerous changes. But they will go in there, lop off the damaged part, remove it, pull the stomach up, reconnect it to what esophagus is left, and then they wrap the fundus around to kind of support that, because you don't have a sphincter if you've removed that lower end. So there's nothing really to keep the acid out of the new cleaned up esophagus and keep the acid away from your sutures. You just pulled the stomach up and reattached it to the esophagus. You don't have a sphincter. So the next time you eat food, what's going to happen? You don't have a sphincter, so stomach acid is just going to get right up there and burn away the sutures. So the funduplication is where they take the actual top of the stomach and wrap it around the newly anastomosed area. to support it and create kind of a sphincter-like environment. It's a narrowing of the newer incision there to act as a sphincter.
So they don't necessarily go like on a feeding tube then?
They will probably, in the healing process, they're not going to let acid hit any of those sutures. And this patient probably will be NPO with a tube feeding after this surgery, but you can imagine the complication that we need to watch for after they have pulled your stomach up, attached it to a new esophagus, then wrapped the stomach around. We're not going to put food in there for a while. That's all got to heal. Because if it gets acidic, it'll burn away. Yes?
So do they get dumping syndrome?
So we'll talk about dumping syndrome. Dumping syndrome is the pyloric sphincter. That's down here. So this up here doesn't necessarily mean you're going to have dumping syndrome. We will talk about it, but whenever you screw around with the stomach and move the stomach around, you're going to change the function of the bottom of the stomach. You're going to stretch it. You're going to pull it. The pyloric sphincter might not work appropriately, and that gives you dumping syndrome.
So
We'll talk about that in a minute.
Funduplication, is that only at the top, or can you do a funduplication at the bottom?
That's a great question. I don't know the answer to it. The fundus is the top of the stomach, so I don't think it would be called a funduplication if they did the same thing down here. I don't know what that would be called.
Okay, because I'm doing dumping, our group is doing dumping syndrome, and they're reading words and going, don't know what that means.
Well, we'll get there.
Okay.
So that's funduplication. That's just basically trying to damage it. The esophagectomy is where they remove the entire esophagus because maybe too much of it is damaged and all of it's cancerous or whatever. They will remove the entire esophagus. Sometimes the stomach can be anastomosed, sometimes it cannot. This patient may be on permanent feeding stomach, straight into the stomach. If your esophagus is really trashed, they'll remove all of it and lop it off and just be like, you can't eat anything. It's gone. Everything goes in through the belly.
Still? Does it at all?
It would depend on how much is damaged. It would not affect your trachea unless you've metastasized into your trachea. If that's happening, you've got a trach. So it depends on how bad your cancer is, how much they have to remove. I have a friend who got esophageal cancer. He's a heavy smoker and had Gerd forever. He's not really a friend, he's more of an acquaintance. But he ended up having full-on radical neck construction because they had to remove not only his whole esophagus, part of his trachea, and some of the muscle around his neck because it had all gotten in there. And so when they removed everything, they used muscle grafts to recreate in plastic surgery. But yes, he has a trach and a feeding tube because the whole area got trashed. So I'm not going to tell you exactly what the patient's going to look like afterwards because it just depends on how much you have to remove, whether you're just removing the sphincter or some little bits of area or if you're taking the whole thing down. But, basically, we don't want to get there. We want to teach our patients not to get there. So if they're coming in with Gerd, if you're working in the ED and your patient's being seen for the 4th time for Gerd, you might want to encourage them to stop. I don't know if you've had any pharmacology on the antacids before, or they are acid blockers. Antacids are bicarbonate based. Those are the Tums, the Rolates, the Maalox, the things like that. They're not prescription strength. They are just physically bicarbonate. And what are you doing when you eat a Tums? You're dropping bicarbonate into your stomach, which helps Gerd and ulcers because you're neutralizing the acid with bicarb. But patients who overdose on these, or you take a whole bottle of Tums, I've seen patients just, mainline those Tums. And I'm like, wow, you're taking a lot of calcium and bicarb. That's going to completely screw up your electrolytes. Some patients can go into metabolic alkalosis from just ingesting too much bicarb. You've taken way more than you need to neutralize. If you take a Tums and it reacts with acid, what does it become? You take bicarbonate and show it and put hydrochloric acid and bicarbonate together, it turns into water. So when you take a Tums it's going to neutralize whatever acid it comes into contact with and turn it into water, but then it's gone. It's a one and done thing. So you take one Tums, it'll soak up whatever acid it can find and turn it into water, but then if your stomach secretes more acid, you're going to need another Tum. And so that's not the best treatment. We tell patients to try to avoid them because it causes electrolyte imbalances, and it's a very quick fix. It's great for one-time use or occasional use, but it is not for treating GERD. It doesn't allow the esophagus to heal. It doesn't change the acidity of your stomach. It doesn't do anything really useful other than a one and done. So we tell our patients not to do it. What we do recommend is either an H2 blocker, those last 12 hours, or a proton pump inhibitor, which lasts 24 hours. You choose. If you feel like you never get GERD during the day, but you get it when you sleep, then taking maybe an H2 blocker just in the evening might be your choice. If you need to block acid all day long and never have enough, then that is a PPI or proton pump inhibitor. You've probably given a ton of them. They are all available over the counter. I like the H2 blockers are dines. They allow you to dine pain-free. And I haven't come up with one for the Zols. But I like the dine pain-free. That helped me a lot when I was coming up. But they are both taken before meals because, of course, you want to block the acid before the food gets down there and everything starts burbling around and it bumps up. So all of your H2 blockers and PPI should be taken before meals. Their most common side effect is headache. Long-term use of both of them can cause a B12 deficiency. And that is because your stomach, in addition to creating acid, gastrin, pepsin, creates intrinsic factor, and that is used to bind B12. So when you block the stomach cells from doing their jobs and producing, you're also blocking them from producing intrinsic factor, and that leads to a long-term B12 deficiency after amount of time. Now, your dose of these depends on how much acid you're blocking down. A smaller dose will block down not every single piece of acid your body makes. You'll still be able to digest, but it reduces the pH. It increases the pH of the stomach. So instead of producing 100 milliliters of acid, you'll produce 50 milliliters of acid instead. But you can imagine what that's going to do to your digestive process. It's going to take longer and more pancreatic secretions to digest your food because most of the digestion, the acid has been blocked. So we do it to save the esophagus and allow the esophagus to heal in between its bouts, or hopefully prevent bouts of GERD so that the esophagus can heal itself. So we like to give them to patients, but we would rather them learn the anti-reflux rules that are in Teach and Communicate. That would be a better long-term solution than taking these forever and just being like, eat whatever you want. Just take your proton pump inhibitors or your H2 blockers. The problem is the long-term use. The long-term use gives you issues with your digestion and issues with B12 deficiency later on. So if you're taking them for years and years and years and years, you may end up with some deficiencies later on. So we do want to tell our patients to teach them to avoid reflux. So this is a big one. Not just take some meds and coat it with meds, but you need to do this on top of it because we can't have you on these meds forever. So we'd rather you get this under control, use the meds to let your esophagus heal, and then keep GERD under control. We're keeping GERD under control, upright for 2 hours after meals. It makes sense. If you lay back, stomach can reflux. Avoid eating 3 hours before bedtime or before you're going to lay down. Don't take a big lunch and then take a nap. You're going to probably have reflux. To avoid caffeine drinks, alcohol, chocolate, peppermints, fatty foods. They just stimulate more acid secretion. Small, frequent meals. Don't distend your stomach. You're going to get GERD if you distend your stomach all the time. Smoking is a big problem in the upper GI tract. Smoking does bad things to your upper GI as you inhale or vape or do whatever. Half of that, what you're inhaling, doesn't get into your lungs. You know you're swallowing half of it. If you're inhaling, some of it's going down your esophagus as well. So what is toxic to your lungs is also toxic to your esophagus. And so smoking has a big correlation to esophageal dysfunction, because when you inhale whatever it is, not all of it goes into your lungs. So that you're putting that in your stomach as well. Eat slowly, chew food well, all the stuff your mom taught you all the way, but just trying to prevent the patients from using PPIs and H2 blockers for the rest of their lives, because they will cause problems later on. And like I said, the biggest risk factor for GERD advancing to Barrett's esophagus are smoking, alcohol use, obesity, basically not taking care of yourself and allowing that stomach to distend frequently and cause more GERD episodes. So that's GERD. You got it all in one little remit done. Want to take a break? Well, we'll finish this real quick and then we'll take a break. We'll do our lunch in just a minute. The next one is just ulcers. Stomach ulcers. They are stress. So nursing school is definitely an emotional stress. Physiologic stress, like getting a major illness, having a major surgery, having a major injury, something like that. That's a physiologic stress. Emotional stress would be anything that we're going through all right now. H. pylori is a bug that it's a bacteria that loves acid. It loves acid. It wants to make its home in acid. Bacteria are amazing. They can live almost anywhere. And H. pylori loves the stomach. And this is a bacteria, and if you get infected with bacteria, it eats away at your stomach wall and causes ulcers. And non-steroidal anti-inflammatories cause ulcers. You always hear it's a big risk of bleeding, GI bleeding, and you don't need to know why, but just know that non-steroidal anti-inflammatories do increase the erosion of the gut. So you're at high risk for bleeding unless you get like a really big, strong, I must have a stomach wall of iron because I've taken Motrin my whole life. Ulcers are gastric pain. It is burning or gnawing. It's usually 1 to 3 hours after food intake because that's when your acid level is the highest and you are actually exposing your stomach wall to acid. So the pain usually happens if you have an ulcer after you eat while the food's in the stomach. The pain can be relieved by foods, antacids, or vomiting because all the foods, vomiting gets the acid out of the stomach. Antacids stop the acid from being made as much. And food actually neutralizes the acid because if you put food in there while the acid is being produced, it's all mixing together and becoming other things other than acid. So sometimes people are like, yeah, it hurts when I eat, but then it gets better but as you process the food and digest it, if the stomach's still producing acid, you end up with that acid gnawing feeling. Possibly weight or appetite loss. The worsening cues is that ulcer getting to the point where it's not just hurting the nerves. And think about it, your stomach is just like your skin, even though it's a muscle. But if you start eroding, if you get an erosion, you'll erode through the epidermis first and then down into the dermis where the nerves are and stuff. Ulcers happen the same way. It's the surface area that gets damaged, and then it erodes further down into the nerves and further into where the blood vessels are. And if it erodes down to where the blood vessels are and those blood vessels get exposed to acid, then they can bleed. So a bleeding ulcer is a worsening cue, and that would be vomiting up blood. Now, if you have blood in your stomach, you're going to either vomit it up, or where else is it going to go? It's going to go out the other end. So you could have black tarry stools. As blood moves through your GI tract, bright red blood means it was very close to where it exited. Coffee ground emesis means that the blood has been exposed to acid and has curdled, basically. So if you see coffee grounds, which literally look like coffee grounds, when we do SIM, we put coffee grounds in the red stuff because it does look like coffee grounds. And that is the red blood cells and all those components are curdling and creating coffee ground. We only see coffee grounds if they're vomited up. If other stuff moves through, so if you're bleeding and it goes past the pyloric sphincter and gets into the GI tract, well, it will be changed by all the bacteria and stuff and the digestive enzymes. And the longer it's been in the GI tract, the more sticky and black it is. So a very, very black stool is blood that has been in the GI tract for a long time. The lighter color of the blood in the stool, the less time the blood has been in the GI tract. So does that make sense? If you see the word melena or black tarry stools, I want you to kind of associate that with, that's been blood that's probably from a long time ago. If you have frank blood in your poop, it came very close to the exit, so it's probably just the rectal area or like a hemorrhoid or something. But if you're seeing dark stools, dark red stools, the darker it is, the longer the blood's been in the intestine. So you can kind of guesstimate where your bleed is by looking at your poop. Anemia, of course, because you're bleeding. And BUN is blood, urea, nitrogen. When blood is broken down, when blood is digested in the gut, so let's say you bit your tongue and you swallowed a lot of blood, then your BUN will go up. Because when the gut digests old blood cells, it makes urea. It's a fun fact. This does not mean you have kidney damage. If you have a GI bleed, your BUN will go up, but guess will not go up? Your creatinine will not go up because you didn't change. There's nothing wrong with your muscles and how they're functioning. Creatinine is a muscle breakdown or a protein breakdown thing. This is just for blood. So if you have a high BUN, no signs of renal failure, and no high creatinine, there might be a bleed somewhere in your gut. Fun fact. The worst case is that your ulceration goes through your stomach and creates a hole in your stomach and perforates your stomach. Where is it going to leak to? Is it above or below the diaphragm? Below, so it's going to leak into your abdomen, and it's going to cause abdomen infection or a peritonitis. Questions? No?
When does that happen?
Not very often, because I'm thinking that the pain from this will get someone to seek treatment before it perforates. I mean, if you're eroding through your skin all the way down, it's going to hurt. Those nerves get really, really damaged, and pain is your signal to go get taken care of. So a lot of people will go in there and find the ulcer. And the treatment for an ulcer, well, we're here, but you're going to still ask them their pain level location, because really this is a lot related to food. But you are also looking for bleeding and infection, because we know those are the worsening cues. So we'll probably ask for blood pressure, heart rate, temperature, because if they're getting an infection or something, or their pain is worsening, you're suspecting maybe this erosion through the wall, then we would want to check the blood pressure, heart rate, temperature for bleeds, hemoglobin, hematocrit to assess for any bleeds, and the BUN level, because breakdown of blood in the GI tract does create a higher BUN. So the interventions, if you're not bleeding or infected yet, you just have an ulcer, you have existing cues, then it's acid reduction. Same as Gerd. Get rid of the acid with the H2 blockers or the PPIs. Pepto-Bismol, because the H. pylori, if it's a bacterial infection, how do we test for a bacterial infection in a stomach? How do we test for H. pylori? Quiz question? No, not quiz question. Fun fact question. Nope.
Aspirin?
Nope.
Don't you have to breathe?
It's a breath test. The H. pylori releases enzymes, the bacteria does, that are detectable through a breath test. So it's like a breathalyzer test. If they are suspecting an ulcer, they'll probably send you for this H. pylori breath test. And it is very simple. You just breathe into it like a breathalyzer, and it tests for the presence of H. pylori.
Will you have bad breath if you have H. pylori?
I don't know about bad breath. Maybe. I don't know if what they're producing down there is toxic and makes your breath smell, or if they just detect it in the breathalyzer. Yeah, I don't know. Maybe. Ask your doc. But they do diagnose H. pylori with a breath test. And if you have H. pylori, then they will give you antibiotics and probably recommend that you take Pepto-Bismol, which isn't normally, that's an antacid. It kind of coats the stomach. It doesn't do much for reducing your acid production long term, but it kills H. pylori. So antibiotics and Pepto-Bismol are the expected treatment for H. pylori. If it's a physiologic or stress ulcer, then they're just going to shut down your acid production until your stomach can heal up a little bit. But whenever you shut your acid production down, that's not free reign to eat whatever you want. You shut your acid production down. You also need to do those reflux and Gerd items as well to heal a ulcer. If you are GI bleeding or getting close to perforation, if this ulcer is having worsening cues, then you're still going to do acid reducers. The reason being is that clotting factors don't work in a pH of 2 to 3, or even 4, or even 5. Your clotting factors need a normal pH to work. So bleeds in the stomach don't stop. They don't stop unless you basically knock your acid production way down. Bleeds in the stomach are very hard to stop because your clotting factors don't work. Fluid replacement, obviously, if you're bleeding from anywhere, we're going to do fluid replacement, possibly blood replacement if necessary. Endoscopy is the key diagnosis for any kind of ulcer. It's really the only way they can see if you have an ulcer. So you're going to get the camera to find the source, and they can also do things in there. If your GI, so we told you your clotting factors aren't going to work, the endoscopy will. They can physically go in and cauterize the vessel that's bleeding and make it stop bleeding. So it's going to be very hard for you to control bleeding once it starts with just acid reducers, but they will try it. They will also do endoscopy and IV vessel vasoconstrictors. There are 2. And you may, if you have a patient who has an upper GI bleed, it's only appropriate for upper GI bleeds because it only compresses the blood vessels around there. So it's kind of like putting pressure on the vessel from the inside because we are clamping down the gastric vessel flow. But that can cause issues with your gut. We don't want to do this for very long. We only want to do it for long enough to stop the bleeding. But that's because GI bleeds in the stomach are hard to stop because we can't use our clotting factors very well. So usually they have to kind of go in, and if you have an upper GI bleed from a stomach ulcer, you may see a variety off these menus. I like for you to think of the interventions as a menu of options that the physician or the provider has. So now you have access to the menu so you can see what's appropriate for this patient, but the doctors can choose these things in any order, and you may implement them in any order. If your patient is GI bleeding and you have an order for an acid reducer, fluid replacement, endoscopy, blood replacement, and an octreotide, you have an order for every single thing on your menu. Which one do you want to do first? What do you think? Now knowing, let's say, and I'm going to give you a little bit of a patient scenario because I don't think it's fair to ask you what to do first if you don't know what your patient looks like, right? How can you prioritize if you don't know what your patient looks like? You've got an order for everything on your menu. Yes, 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 yes. Which one do you do? It's going to be different based on your patient. So our first patient, who is upper GI bleeding, he's got coffee ground, bright red emesis. His blood pressure is 120/80. His heart rate is 90. His O2 sat is 96. Is this patient in distress? No. Doesn't sound like he's in distress. So when you draw your hemoglobin hematocrit, it's on the low end of normal, but it's normal. His BUN is normal. What order do you now do for this patient? What's the priority for this patient? He has a GI bleed. He's got coffee ground emesis. He's got black tarry stools, but he's stable. What do you want to do first? So this one kind of moves down. If your patient, if I had given you the unstable patient, this would move up. But he's not that unstable. It's a good idea, but it's not my huge priority. My first priority on a bleeding patient would be endoscopy, but I can't control that. So I would probably do my acid reducer first because I would like to bring down the pH of the stomach as much as I can to try and let the clotting factors work the best they can. Get the acid reducer in him. He has blood product replacement, but it has, 1 unit. It's not a priority at this point because his hemoglobin hematocrit are good. So yeah, it might be there, just do it because we know he has a bleed, but it's not my priority. My other priority, if I had an order for this, would be this one. I would start my acid reducer and my octreotide because I know those are going to get in there and help me solve the problem until he can get to endoscopy. That is the final solution to the problem. If I have time before endoscopy, maybe I'll give the blood, but it's not a priority. So your priorities would be get the things in them that will try to tamp your bleeding down. That would be your octreotide and your acid reducer. Then go into endoscopy to finish that. And then if you got some extra time, sure, the fluid and the blood. But this isn't where I'm going to be goofing around with his IV, starting his IV, calling for blood, getting all that, taking about a half an hour to get my blood and my fluids in, when that whole time you could have been having the meds that will work better in the system. So kind of think to yourself, what would I do? And it depends on your patient. Now, if I had given you a patient with a blood pressure of 88/40 and a hemoglobin of 10 and a hematocrit of 20, and, he's not oxygenating well, he's having more trouble, now might change to get the blood right now. I mean, you want to do the acid reducers in the GI vessel, but we have a worsening condition on our patient that he's bleeding to the point where he's got a low blood pressure. Our priorities become fluid replacement, blood replacement, and then the GI tract. But our GI tract's already been bleeding for so long that we've lost a lot of blood. So our priority becomes fluid and blood, then the acid and the somatostatin, then the endoscopy. The endoscopy is probably going to take a while. We have no control over that. I'd love to get them to endoscopy right away. Sometimes if patients have a low blood pressure and bleeding, they start fluids, blood, and send them to endoscopy. And we don't even get to the acids before they whisk them off. But sometimes endoscopy's backed up. We can't get in there right away. Then we have to rearrange our priorities. So I like to think of interventions rather than what order do you do them, because it's going to depend. Think of it as a menu of options. If you know what the items are for, if you have the description off the menu, you can start trying to figure out which ones are the most important. So you can see a little bit of how your priorities change based on your patient. But as long as you have your orders off of the menu, it's appropriate. If the orders are not on your menu and they don't make sense to you, they might be inappropriate. Do you have a question?
Yeah, last semester during clinical, when I saw them do an endoscopy, they were going in and doing a biopsy because the surgeon thought that he saw H. pylori. Why would they take a biopsy?
I think if they're already in there, they're probably just going to look around and they're going to check the cells. The bacteria live in the cells. They're not just kind of circulating around in your stomach. They actually physically live in the cells. So they're probably taking a couple of the cells and looking for H. pylori. I don't know why they just didn't do that, but they probably were in there anyway and just figured we might as well check everything out while we're in here.
I just wondered why they would do that instead of there's just a breath test,
Maybe the breath test was inconclusive. I don't know. Or they were just in there looking to see if he had Barrett's esophagus or something, and they were like, well, we're in here anyway. Let's just take a few and take a look at everything. So the teach and communicate, again, all the risk factors from Gerd and things like that, but mostly stress and smoking, and avoid NSAIDs. These are what you expect and don't expect after an endoscopy. So you send your patient for whatever reason for an endoscopy. We do expect you just shove a camera down the throat, sore throat, a cough-producing light pink sputum. Well, if they scratched up the esophagus or the stomach a little bit, or they did a biopsy, there might be a little bit of blood left in the system, and you might kind of move that forward when you cough. There might also be pain when swallowing. That's all expected. We just shoved a camera down your throat. We do not expect bleeding. We don't expect that camera to have punctured through any of this stuff, but hey, if there was a hole there and it was kind of weak and they were biopsying and they were going around, there could be a perforation, so we would want to keep an eye out for the perforation. If it's esophageal perforation, it would be severe chest pain. If it's a stomach perforation, it would be abdominal pain, because that's where the stomach stuff's going to last. Also, if you do perforate, you're going to get infected. You're putting either food or acid or half undigested food into your thoracic or abdominal space. So any perforations are going to cause what looks like a pretty intense inflammatory and possibly infection. The first time, how long does it take for an infection to grow so that you can see the effects of an infection? So let's say he perforated during his esophagectomy and I'm taking care of him an hour after. Am I going to see infection or inflammation first? You're going to see inflammation first. What's the temperature on inflammation? High or low? Low grade. Then over the next 12 hours, bacteria, it depends on how fast the bacteria replicate. from whatever infection you've introduced. So whatever bacteria was in that food or in that stomach or esophagus that perforated, whatever that bacteria is, are going to get in there and kind of colonize and grow. It takes a little bit for the infection to show up. So I don't want you to think as soon as you perforate, oh my God, they're going to have a screaming high fever and they're going to have all the signs of infection. It takes a while for an infection to build up. So we'll see what looks like inflammation for a while first, low-grade fever, pain, swelling, and then it develops into the infection over 12 to 24 hours. If it's bacteria, if it's fungus or virus, it could take days for an infection to really grow. But your white blood cell count will go up in an inflammatory process as well. So really your fever and your white blood cells are your best indicator of an infection process going on. Your white blood cells will go up as soon as inflammation starts, and then they compoundly go up as your infection grows. Fever starts out low and gets higher and higher. High fevers are usually bacterial. If you have a virus, they say your fever doesn't really usually get higher than 102. It's a low-grade fever. Once you start getting over like 101, 102, we're starting to talk bacterial as well. So anyway, it is the esophagus. It does share innervation with the heart. So you may have some cardiac chest pain or arrhythmias afterwards, especially if they biopsy the esophagus, because the body can't tell, is this heart pain or is this stuff? I'm not really good at sharing that, so it might irritate the heart a little bit. And respiratory depression, sedation, you do get sedation for endoscopy. You want to make sure they're not over-sedated. And I think that's about it. So we just, this is just kind of just some key things just about post-hair procedure and what you're going to teach your patient about. And then gastric surgery. Here's dumping syndrome. This is kind of where I put it because it's very common after gastric surgery, like if we had a funduplication or a pyloric sphincter change, or even reducing the size of the stomach when they go in and do gastric bypass surgery. They basically lop off a lot of the stomach and make the stomach the size of a large tube and then connect that large tube. So you don't really have a distendable stomach. We see so many side effects after gastric bypass surgery. You have to take care of yourself after gastric bypass surgery or the ramifications are really bad. Because imagine you just basically take your stomach, lopped it off, and they staple it all together and sew it all up and put you basically take a big bag and cut it in half and sew it you can imagine if you try to sew together a plastic bag or a rubber bag, there's going to be leaks and holes and stuff in it, so they are not allowed to eat. All patients after any kind of cut in the stomach, we generally are NPO afterwards. Think about in fact, you put sutures in the gastric system. They really shouldn't be getting stuff put into that system right away until there's healing. How long does healing take? How long would you think that takes? I told you get a new GI system every 3 days. So how long? I would probably give it a couple of cycles of healing, but I mean, we're looking at probably at least 2 to 3 weeks before they probably let you eat. Or they might introduce foods slowly, like liquids that don't require a lot of churning and burning and distension. Small amounts of liquids frequently that will just pass right through. So NPO or clear liquids usually is what your GI patient is in until the area heals. So NPO definitely until your bowel sounds return, your intestines are working, because whatever we put in there, if we do put something in there, needs to be able to pass through and not get stuck there. So if your bowels are not moving things through, I'm not going to re-lecture you about bowel sounds, but how do you listen to bowel sounds? Each section, and for how long? Don't tell me 2 minutes. No one listens for 2 minutes. This is understandable. No one's listening for 2 minutes. What you're listening for is 2 bowel sounds, 2 gurgles. And you want to take a listen to how long those gurgles are apart. If they are gurgling like every second or 2, that's kind of hyperactive. If they don't gurgle at all in 2 minutes, the 2 minutes comes from you need to listen for the full 2 minutes before you say there are no bowel sounds. So we know nobody listens for 2 minutes, but I know people who go, no bowel sounds. I'm like, you didn't even give it a chance. No bowel sounds, we will talk about later, is a terrible finding. It's like no pulse. don't write it in someone's chart. It means there's a problem. So don't write absent bowel sounds, because absent bowel sounds means a paralytic ileus, which we will talk about later. You don't want to diagnose someone with a paralytic ileus. They probably do have bowel sounds. They're just really hypoactive. If you gurgle at any point in the first minute, you have bowel sounds. If you gurgle in the second minute, you have a bowel sound. It just wasn't very good, but it's hypoactive. Absent bowel sounds or no bowel sounds means not a single gurgle in 2 minutes. It means your bowel is paralyzed. So if you're charting absent bowel sounds, you've made a very big diagnosis. It's like an absent pulse in a foot. That means you don't have blood flow to your foot. So you own a little bit of responsibility for what you put in the chart. And if you are charting absent bowel sounds, the doc's going to be like, what? We need to do some investigation into this paralytic ileus. And you're like, oh, I just didn't really listen. Don't do that. But anyway, they may have an NG tube. What would be the point of an NG tube? We're going to talk about NG tubes in a minute, but what's the point of that? To make sure that any acid that gets produced or any fluid that might distend this area or damage these sutures gets pulled out. Okay? These are patients that have an NG tube to wall suction. Most gastric patients will have an NG tube to wall suction, and that's to let the area heal and keep acid out of the healing process. As soon as it gets produced, it gets sucked out. Most of them will. NPO, meaning nothing by mouth until your bowel sounds return. And then after bowel sounds return, it is up to the physician to direct advanced diet. But on most GI patients, I would limit to clear liquids until the physician says otherwise. Burning pain, sure, they just did surgery there. JP drain, sure. Dumping syndrome is due to the duodenum, and that is an issue with your lower pyloric sphincter there, and that for some reason getting a full duodenum does not fix your sphincter, and your stomach just keeps dumping into the duodenum. And the duodenum's like, dude, I'm not done. We haven't even added more. I didn't move. Oh, fine. And so then that duodenum starts to swell. Duodenums don't swell as much as stomachs do. It's a smaller bore intestine, and it's got work to do. It's trying to insert things in there, and it's holding things up until it can move through. If peristalsis is low, or if the pyloric sphincter is not good and food's just dumping out of the stomach and distending that duodenum, then the nerves that are infiltrating the duodenum there are sending signals to the brain. Something's wrong. Something's wrong. Too much stuff is hitting me. I can't handle this. I just can't handle this. And it's called nausea vomiting. The body will respond with trying to move things faster through. You're stimulating that vagal nerve, which is going to cause everything to move a little bit faster. Dizziness, palpitations is just from the nerve innervation sending signals to the brain. You actually end up with tachycardia and sweating as well. It is just the sign that the duodenum is being badly controlled, that everything from the stomach is dumping into the duodenum, and the duodenum can't handle it. The stomach's designed to swell, the duodenum is not. Yes?
It might be the dizziness, palpitation, and tachycardia might be from hypoglycemia because they get so much sugar all at once, and then their body...
It could be, and also the liver and the pancreas are dumping into there, and so that pressure sometimes works on the pancreas, and that causes an issue with your insulin secretions as well, because it's all just pressure in that area. You'll see that when we do the liver pancreas. So it's a good question. I don't really go into the pathophysiology of tachycardia and sweating, but yes, it could be a hypoglycemia issue. I'm not sure, and that's why you're doing that research article. What is the issues with dumping syndrome that I didn't do? I sometimes update these PowerPoints based on what you find in your research on your EBP projects. I try to give you interesting topics, things that relate to your learning. But if you can give me a good reason for that, an evidence-based reason why you get dizzy, tachycardia, and sweating, I'll add it in there. But I didn't research that. I'm giving that to you. So dumping syndrome, we kind of expect it because we just changed the whole stomach. That pyloric sphincter is not working appropriately. And so dumping syndrome will not happen until you start putting food into there. All right? If you have an NG tube, you're not going to get dumping syndrome if it's to suction. We kind of expect it when we start putting food into this system because the pyloric sphincter might not have healed well, and then there's the risk of dumping too much into the duodenum, and the duodenum can't handle it. So when you're hearing dumping system, that is from the stomach to the duodenum. And it just means that that pyloric sphincter is dysfunctional. I think, is that it for the gastric section? So what do we do? Let's go back. These are the intervening. This is basically what I'm telling you, you know, kind of, here's the healing process. This is the most common. This is not a law, a rule. Docs can change it based on whatever surgery they have. This is just a guideline for patients post-gastric surgery in case you're not given a guideline. This is kind of how things advance after gastric surgery. Clear liquid diet, then a full liquid diet, because liquids are okay as long as you're not drinking like a liter at a time and distending out those sutures. Education about the small frequent meals, including liquids. Liquids should be small and frequent as well, because we don't want to distend any of the stressing on the suture lines, because stressing a suture line in the stomach or in the lower intestine is going to cause a more higher risk of perforation, or bleeding. So we don't want them to do that. Pain medication, yes. This is prophylactic antibiotics, DVT prophylaxis. That goes with almost every surgery, right? I mean, just coughing and deep breathing. They've just done surgery around this area. It's gonna affect the diaphragm. So they're gonna have atelectasis, and we're gonna make sure that they do cough, deep breathe. We don't want them throwing up if possible. That's the other reason for the NG tube. We don't want them vomiting, because that reverse peristalsis can affect your sutures as well. So kind of common sense, hoping. You know, if you think about the fact that we just got sewn up a stomach, these are basically don't let your stomach get distended if you had stomach surgery. Eat small meals, don't distend your stomach, prevent gas buildup. Like I said, they have an NG tube for a while, but even they're still healing for 2-3 weeks. If their NG tube's been removed, they need to know, don't swell your stomach, man. It's gonna pop something. And most of it is just the Gerd teaching applies for post-gastric teaching as well. I think that's it. Yes, now we're going to lunch. So, thank you. I will pause this. I'll try and speed up a little bit, but I don't want to. I figure the voiceovers can be longer because you can fast forward through them or not listen to the parts you want. But sorry if you're listening to them live being recorded because they feel long. All right. The first one, out of the intestines. So we talked about the issues with the esophagus and the gastric. This is by no means an extensive or everything that could happen with the intestinal system. Fill in your book for details, for more details, but really what I'm going to test you on is our curriculum, which is what's listed in the module. If you find out more, I'm going to recommend to you guys, and I'm putting this on the recording for posterity, that if you are doing your U-Worlds, and I've probably said it before, but if you're doing your U-Worlds, your prep U's, or looking at Saunders, or looking at anything, and you're compiling more information, your textbook, all these things, I recommend you do it after you've listened to the voiceover and you're like, I think I'm getting it, I'm getting there. When you learn new things that you're like, I never learned that in class. Oh my gosh. Make a notebook for yourself, what I would recommend, whether it's a 7-subject notebook or a binder or whatever, and do them by body systems, just for med-surg. I'm not sure how you want to arrange OB or peds when you get it. But for med-surg, do like a neuro section, a respiratory section, a GI section, a cardiac section, just sections for all of the skin, those things. And as you learn interesting tidbits or facts from rationales of questions, just because you didn't get it in class doesn't mean it's not going to show up on HESI or the NCLEX. So part of giving you the questions isn't just to give you an assignment, but to expose you to more information than maybe what I've given you in class. So you've probably come across that and you're like, well, that wasn't covered in class. Well, that excuses you from putting that in your head for my exam, but it does not excuse you from knowing it for the NCLEX or the HESI. So put that binder together for yourself, because then you're creating a study tool that you can use for your NCLEX. And so this is just a place where you've learned new facts about something. You're in the GI system now. So if you learn something and you're like, wow, we didn't talk about that in class, just make a little note of something. You can use a flashcard on UWorld. You can even do this through flashcards in UWorld and make respiratory GU and just say, I'm going to make a giant neuro flashcard, or this is going to go into my neuro section. This is a topic thing I didn't know before. And then you have more study tools for when you are actually, and you're also studying for NCLEX as you go along through nursing school, rather than waiting to the end of nursing school to study for the NCLEX. So just because it's not in my PowerPoint or in my lecture, I generally do not try to put things on the test that we have not covered or talked about. But just in case I miss something in this curriculum, I would like you to have it, and that's the point of those questions and things, is to expose you to more. Then take notes off of it. It's good. They're fun facts that you're learning. So, off the soapbox, and get back into view. So, we are now in the intestines, into the duodenal, small intestine, large intestine. We will talk about liver and pancreas in a separate PowerPoint. This is an actual issue in your intestine. It's called diverticulosis. I put the osis in capital letters because this is not an infection. It's just a state of being. It's a state of having popcorn bubbles in your intestine. Many people have these little popcorn bubbles in their intestine. Here's a picture of what the diverticuli look like. They're just little outpouchings that pop out. They are caused by pressure in the intestine. So the more pressure you have in your intestine, the more chances you will have of diverticulosis. Diverticulosis themselves are either completely asymptomatic. Most people don't know they have them until they get a colonoscopy. Completely asymptomatic, but they may have some cramping or abdominal pain because remember, this is a muscle that is constantly squeezing and moving. So if you got a lot of little popcorn bubbles in it, it's going to kind of hurt a little bit as it moves. So just think about, when you turn your neck and it kind of pops and bubbles and things like that. Sometimes it hurts, sometimes it doesn't. Same thing with diverticuli. As that peristalsis is happening, if you have a lot of them, you may have some pain and you may notice them. Most of the time, though, they're asymptomatic, and there's really nothing we're really going to do about it except prevent them, which is in the teaching thing. The worsening cues is these little outpouchings getting infected, which is diverticulitis. Itis means infection. Osis just means you have it. Itis means it got infected. So diverticulosis just means you have them, don't care, or we need to prevent them. So if you are having diverticulosis, this is just a 2-page slide because there really isn't much to say about it. What you're going to do is you're going to be monitoring for worsening, which is diverticulitis. That's why temperature, pain level, location, pain timing, bowel sounds, bowel movements are on there. The prevention is fiber and fluids. And if you're not eating enough fiber and fluids in your diet, you probably got some diverticuli growing in your intestine because low fiber and low fluids causes stool to slow down through the intestine as it's being made, and it increases the pressure in your intestine. Fiber helps things slide through, so does water and fluids. They help things slide through. So if they find diverticuli on your colonoscopy, they will tell you to increase your fiber and fluids in your diet to keep things moving through your bowels and reduce the pressure in your bowels because basically blockages are causing pressure in your bowels. And if you've had frequent episodes of constipation, you probably have some diverticuli in that area. And that's fine, but you want to keep things moving past them. They don't really heal once they've popped out. They kind of stay out. You want to keep things from getting into them. So you will see in the diverticulitis slide, one of the main interventions for a lot of the bowel stuff is a low residue diet. But for these people, just keep things moving past, okay? Fluids flush. If you're going to have stool running past those holes, it would be better for it to run past those holes a little faster and with some liquid. Whereas if it's slow and sluggy, there's much more chance of things kind of escaping into those little outpouchings and then getting infected. So, after you eat and things pass through, make sure you flush it with a lot of water so that as the stool moves through, water flushes it after. Lots of water helps flush this stuff through. So basically, we just try to tell them, all right, you got diverticuli, make sure you keep fiber and fluids in your diet and avoid risk factors so they don't get infected or you don't get any more. The infected diverticuli, if they get infected, you get a fever, you've got abdominal cramping and pain, not just after eating, but kind of at all times. She's got now an infection in your bowel. And you might have diarrhea because whenever you get an infection, you get inflammatory drainage, right? in your finger, it puffs up. In your intestine, it just kind of passes through. So you might get some diarrhea from an inflammatory process. The worsening cues are these diverticuli popping, rupturing through the wall. They can also completely obscure and cause a bowel obstruction. If these little abscesses kind of grow, an abscess can be encapsulated and grow, and it can grow in there and block off your intestine. Don't worry so much about that. We're going to do a whole slide on bowel obstruction. Bleeding, those outpouchings include a blood vessel, those blood vessels might get infected and they might pop. And fistulas, they can actually erode through into another organ. So sometimes you get fistula from an intestine to an intestine. Hang on. I'm going to pause for just a minute. Where are we going? Okay, bleeding. Fistulas. This is where it actually can anastomose and fistula through these little diverticuli. If they're rubbing up against, like the bladder or the liver or something, they make fistulas. It's just their worsening cues. It's basically this intestine outpouching causing problems. So if you haven't seen the stool chart, I love it. It's just like, it's a fun thing to look at. What your stool says about you. There's a Scrubs song. Do you guys watch Scrubs? Ever? It's old. It's an old sitcom. Used to be on NBC. But it's amazing, and I love it. And they have a song that says everything comes down to poop. It is true. You can tell a lot from it. So you're not going to be tested on the Bristol stool chart, but I put that there for your information, because when we ask our patients about the consistency of their bowel movements, we're not just being kind of gross and like, ooh, tell me about it. Let's hear about this bowel movement. It will give us some information about what's going on there. So that's just for your information only. Don't study it for the test. If you have an infected diverticuli and you are having fever and cramping and they know you have diverticuli and they're infected, or they go up in the colonoscopy and they're like, yep, you got diverticulitis. It's an infection. It gets antibiotics. Encourage fluids to flush the bacteria. But now we're going to rest the bowel. And how do we rest the bowel? Either NPO. NPO is always a way to rest the bowel because we don't put anything in it, it rests. But NPO is not very good for people unless we have to do it for keeping them safe. So we really recommend for bowel rest, if you're ever having inflammation or infection in your bowel, bowel rest includes clear liquid diet or a low residue diet. I have another slide on the low residue diet right after this. You can treat cramping and pain with an anticholinergic or an antispasmodic. They were also in your GU lecture. But here they are again. I'm not reiterating them. You will just keep using them. But the anticholinergic medicine, what's that going to do? It's going to slow down that rest digest and slow down the peristalsis, which would help. So that's why they're very useful here. These antispasmodics or anticholinergics, we were using them for the smooth muscle of the GU tract in the GU system. We can use it for the smooth muscle of the GI tract in the GI system. Yes?
If it slows down and causes constipation, doesn't that push more stuff into
So they will need to be, if you are using this, then they need that education on more fluids to flush, to keep things going. Okay, because yes, you are slowing down peristalsis. That could cause constipation. So include fluids in there so that you have less of a chance of constipation. Yes, it's a good question. If it is worsening, meaning you have some of those maybe super severe pain, you have many of them infected, or you're getting those worsening cues with, hopefully they're not to the point where you need interventions, but worsening cues are going to put you in the IV antibiotic category, along with IV fluids, and now you don't get a chance. Mostly they're going to NPO you if you have those worsening conditions or complications, because our worsening conditions were rupture, fistula, bleeding. Yeah, we're not going to be putting food in there now. It's like, now you're NPO. If you're in those worsening conditions, they will admit you, do IV antibiotics, IV fluids, NPO, and treat the cramping and pain. But again, if there are most of these complications, you might end up in surgery to fix, because if you get an infection from these, you're going to have to go in there and get everything cleaned out. So abdominal surgery is big for a lot of the abdominal ailments. There's not much we can do to go in there and clean that up. We can try and clean things up by either not introducing it to the system or flushing it through with water, but there's really not much we can really do about once these worsening symptoms happen. They will have to go in and do surgery to fix a lot of the worsening symptoms. So with diverticulitis, we really are saying follow your diverticulosis education if you're good, if you have no inflammation, not a lot of cramping, fiber and fluids. But once you have inflammation or infection, whoa, okay, now we're going to change it. We don't want a lot of fiber and fluids anymore. We want fluids. But we want this low residue bowel rest diet. This includes making sure you limit, I should just say avoid, not completely avoid, but we want to limit high fiber foods. We want to avoid, when I say avoid, it does not mean tell them you cannot have them at all, ever. You may never eat a lick of fiber again in your life. Well, no. We want to limit it, avoid it. Try not to go out of your way to introduce yourself to it. So that is different. When you don't have inflammation, fiber is great for moving things along. But now you have inflammation and infection, fiber is going to cause a lot of peristalsis and a lot of pain. So we limit fiber when you have an infection or an inflammation. Okay? That's a sticky point for people. But I'm just telling you, fiber is great in the bowel until it's not. In general, healthy bowels, fiber is the best thing you can do for it. But once your bowel is inflamed or infected, fiber will exacerbate your symptoms. So we limit fiber. So if your patient is on a low residue or bowel rest diet, that is a low fiber diet, meaning only 10 to 15 grams of fiber a day, which usually isn't a problem for people because we usually have low fiber diets anyway in our world. Also, no complex carbohydrates, whole grain breads and cereals. We're basically reducing foods that are hard to digest because we're trying to let the bowel rest. So we're not going to put through a whole lot of stuff that is hard to digest. Raw or dried fruits, vegetables, nuts and seeds, because they're going to poke right into those little holes. So whole grain breads, raw dried fruits, vegetables, you're like, but those are good for you. They are good for you, but they are hard to digest. And we're going to give our bowel a little bit of rest. This is why liquids, clear liquids are great, but also, have you heard of the brat diet? Bananas, rice, applesauce, toast. Those are just easy to eat foods that are, and you're like raw or dried fruits. We're talking about the complex, like dates and, apples and things that have a lot of fiber in them. A lot of fruits have a lot of fiber, which is great on a daily basis, but not when your bowel is inflamed. So we're going to limit things that are high fiber. We're going to limit nuts and seeds. We're going to limit fatty foods. Those are hard to digest. And we're going to eliminate dairy because most people don't tolerate dairy amazing. And so it's usually a trigger for a lot of inflammation. And if your trigger is dairy, you would want to avoid dairy as well. So just trying to keep that bowel from working too hard, but still you want to provide nutrients to yourself. So that's kind of just diverticulositis. That's just outpouchings and getting infected. These are the inflammatory bowel diseases. Diverticulosis is a pressure problem caused by lack of fiber. And inflammatory bowel diseases are actually autoimmune problems. Okay, these are autoimmune problems. These are nothing you did. You just got some kind of cruddy genetic code. Your parents have to apologize to you. Also, we are starting to see a big increase over the past 50 years in autoimmune diseases because we're so clean. We're so clean. Before the 50s, 60s, nobody was clean. They didn't even wash their hands in the hospital before the 70s. I mean, come on, we're still new in this cleanliness thing. We're like two generations into cleanliness, maybe 3 now. So that is causing, our immune system is built to keep you, to fight all the germs you encounter on a daily basis. And I am not saying bad things about being clean. It's great to be clean. Unfortunately for our immune system, the cleaner you are, the more bored it is. And it gets easily triggered because it's bored and it starts attacking things it shouldn't attack. Some autoimmune diseases are genetically triggered. We don't really know much about autoimmune diseases. I do believe we do have some EBP projects, and I don't know if I did one this semester on gut biome, But I think that is the new generation of research, is gut biome, and how that attacks, how our autoimmune disease is functioning, our mental health. There might be answers in our gut that we just don't know about. So these are gut autoimmune diseases. Celiac disease is an allergy. It's an allergy to gluten. It's a very easy trigger to avoid and very easy to treat. Celiac disease is an allergy to gluten, and that allergy causes the autoimmune system to attack the villi of the intestine or the little fingers that move things along inside the intestine. So celiac disease, we'll talk about that. And then we're going to put Crohn's and ulcerative colitis together as the official inflammatory bowel diseases. They have their own, awareness support group. Crohn's and ulcerative colitis, Crohn's and colitis, they are together. They are autoimmune diseases like diabetes or any other autoimmune disease. My brain's checked out. These two are triggered by general autoimmune things like stress, illness, heat, cold. It actually physically attacks the intestinal wall. Celiac disease only affects the little villi. This actually changes the intestinal wall, and there is an increased risk of colorectal cancers if you happen to have Crohn's or ulcerative colitis. My apologies to anyone in the room with Crohn's or ulcerative colitis or celiac disease. If you have more information, let me know. This is basic information. So this is celiac disease. It's damage to the villi only, no change in your bowel wall, so no increased risk of colorectal cancer. But it does cause impaired motility because the villi are the little finger-like things on the inside of your intestine that moves things forward. So to decrease impaired motility, you can have diarrhea, constipation, you can have bloating, flatulence. But because your villi are also where your nutrients are absorbed, you end up with some malnutrition from celiac disease if it's damaged your villi. So you get malnutrition, weight loss, vitamin deficiencies, failure to thrive in children. You get allergic symptoms because it is an allergy, rashes, joint inflammation. And if it is worsening, we see that in terms of worsening malnutrition and vitamin deficiencies and anemias, but it never damages anything other than the villi. So it won't damage your whole bowel wall, but it's bad enough. The tests are for gluten antibodies, where also the doctor will ask about your pain level, bowel sounds, bowel movements. It doesn't cause bleeding. It doesn't erode the intestinal wall. So there's really no other symptoms other than decreased motility and malnourishment. The treatment is a gluten-free diet. If you get your symptoms back, then that's probably because you ate something with gluten in it. And if you're having a flare-up or you're having pain or symptoms or issues with peristalsis, it's probably because you ate some gluten, and it's a good idea whenever your bowels need to heal to put it on Bowel Rest or a low-residue diet. And we're just going to teach the patient the gluten-free diet, and the gluten-free diet is any rice, wheat, barley, and oats. I was eating popcorn the other night, and it said whole grain popcorn. And I'm like, it's corn. Is that a grain? And I'm like, well, if corn's a grain, of course it's whole grain. It's a kernel of corn. Like, packaging's gotten crazy. So we're going to talk about Crohn's and ulcerative colitis together. So celiac disease, gluten-free diet. Crohn's and ulcerative colitis, they have the same treatment and the same teaching, so I put those together, but the symptoms are a little bit different. Crohn's damages your entire bowel wall. I love the picture here of what is going on in a Crohn's attacked section of the bowel because it looks pretty hairy. I don't know how it picks the areas of the bowel. I have a picture further on that I should probably move to this slide. I like this picture down here because it shows that Crohn's can attack multiple places in the bowel, whereas colitis is only in your colon. Okay, so I like that picture later on. I might move it to this slide, but I like these pictures too because they show what's happening in the bowel wall here. What's happening is whatever trigger you have for the autoimmune disease, usually stress is the biggest trigger for an autoimmune disease. So of course, if you have Crohn's disease and you decide to go to nursing school, you probably might trigger yourself into a flare-up. During a flare-up, there is inflammation that is changing your bowel wall. It's attacking your entire bowel wall. Your white blood cells are going in there and eating up your bowel wall, causing swelling, scarring, and inflammation in that area of the bowel. If you would like answers to that, I don't know why. It's autoimmune. The symptoms of a flare-up are intermittent bloody diarrhea, which means this area, when it's inflamed, bleeds. There's lots of blood vessels in your digestive tract because you're absorbing things out of your digestive tract. Lots of blood vessels in there, and inflammation and breakdown in that area can cause bleeding. Constipation. People are like, well, how can you have diarrhea and constipation? Well, this area is bleeding. So I'm going to draw your little picture. Me and my pictures. Let's draw bleeding. Let's get gory here. All right, this area is bleeding. Woo, it's bleeding. But this area, let's say it swelled. So now I'm going to draw, let's see, we've got a swollen area. So this area is swelled and blocked up. So what's coming out your rear is all this blood. Well, blood's going to carry along anything with it, and it's going to be like a little tidal wave coming out. But this area swelled and caused a blockage. And so you've got a blockage behind it, but you've got bloody diarrhea. So I hear so many people going, he had a bowel movement. There's no way he could be constipated. You can have diarrhea and constipation very easily. Your intestine is, God, how many miles long? You can have free-flowing stuff below, and you're just pooping stuff out, but then you've got a blockage up ahead, or up higher. So, yes, you can have constipation and diarrhea together. And that's because this whole area swelled up and caused a blockage. But then it's also bleeding, and that's coming out the other end. So,
I had a doctor say that my daughter had some like issues for years, and she ended up being like massively backed up from a medication she was taking, and he had said that diarrhea can also move around constipation.
it can squeak through.
Yeah.
So if you were bleeding, so let's say, let me change my blockage to, let's change my blockage to right here. So this thing is already looking like it's getting a little blocked. So let's make this the blockage here. So here's your blockage. This area above it is still bleeding, but that blood and that mucus and that inflammatory tissue can squeak around a swollen wall or get through if it's blocking on this side and there's just a little channel left, if it's swelling from both sides. So if I draw it probably a little more efficiently, let's say it's swelling from both sides, but it's left a little channel to move through here, then you still can get the peristalsis is going to be cramping all along there. So if we're looking, this is going to be cramping harder now, trying to push something through that blockage. So you get a lot of cramping up here. And it will squeeze some stuff through, but what's getting through is not very much. And it's mostly mucoid or bloody or something, and it is making its way through. So to anyone that's like, well, I didn't pick diarrhea because I have constipation, you can have both. So cramps and pain, again, because if there are blockages or swelling, it's got to work a little harder to pass stuff around that. Low-grade fever. It also is much more prone to constipation because if this wall looks like this and is swollen and inflamed, those villi aren't moving things. It's just rough in there. So cramps and pain, low-grade fever because of inflammation, loss of appetite, weight loss, fatigue. That area of bowel is not absorbing what it should be, so you may have malnutrition depending on how much of your bowel is involved. They will do a CT or a colonoscopy to diagnose it because it's in that small bowel. It's in that blind spot. We can't get to it with either camera, so a CT scan is needed if it's small intestine because we can't see really the small intestine. So a CT scan will show thickening of the intestinal wall, and if they can get a picture of it, it looks like cobblestones. Worsening cues is, of course, bleeding causing anemia or hypotension, bowel obstruction, or infection. What do we do to treat it? Well, first we're going to talk about colitis and the differences. Colitis was just in the colon, so Crohn's could be anywhere, mostly usually small bowel, can be in the large intestine too, but Crohn's causes changes in the bowel wall. Ulcerative colitis, this is an autoimmune as well, but it attacks the lining of the wall, but it does erode the colon wall down to the blood vessels. So it takes all the villi and anything, the first layer of the bowel wall, and eats at it, attacks it, until it starts to bleed, an ulcer. So it's called ulcerative colitis because your colon is ulcerated, and so you're going to bleed and bleed and bleed. Because it's at the end of the tract and it's not causing inflammation, there's not as much constipation. Ulcerative colitis erodes away. Crohn's causes swelling. Ulcerative colitis erodes away. So there's no constipation because there's not as much swelling. It's still got an inflammatory response, but it doesn't cause swelling because it's eroded away that bowel wall and those villi. So it's mostly persistent bloody diarrhea. It's bright red blood because it's happening in the colon and it's at the very end of the tract. So it's usually bright red or some light red bleeding because it's very close to the end of the tract. It's not dark. Still cramps and pain because things are trying to get through, and also we've eroded down to the nerves. It's going to hurt. Loss of appetite. Again, your colon is this is where we reabsorb water, where we reabsorb a lot of our rest of our electrolytes and stuff, and that's not being done in an ulcerated area. The villi are gone. They've been ulcered away. So we do have some malnourishment, and then when they do a colonoscopy on it, they may do a CT scan, but they can see the whole colon with a colonoscopy. They will see these bleeding ulcers. Bleeding causing anemia or hypotension or infection are your concerns. So, what do you think you want to do for an autoimmune disease? Don't move forward yet. What do we do for autoimmune diseases? Treat the symptoms, but how do we control an autoimmune disease? We usually give something to suppress the immune system. It's an autoimmune process. So if it's an autoimmune process, we're going to do it. So here's your little slide showing you that Crohn's can be all over. Colitis is just in the colon. There's your assessments, which is just a good GI assessment. We are going to do immune blocking. They have created GI-specific immunomodulators. And they are aminosolicitates. So that's your big key for Crohn's or ulcerative colitis. They both have the same treatment. Because they are autoimmune, we use GI-specific immunomodulators, which shut down the immune system only in the GI tract. How nice. It doesn't affect your general immune function. So that is the choice. And that is a daily med that you need to take for a lifetime to shut down inflammation in the GI tract. So it's named they're the enes, mesalamine or sulfazalamine, and I can't say either one. When you are in a flare-up, if they're severe, so if you've got a blockage or you have the worsening symptoms, they may throw some steroids on it. We will talk later about why steroids are not a patient's best friend. They are only used in short-term things right now. We do not like steroids for people, and I will tell you why in the endocrine class. Immunomodulators or full-on anti-rejection medicines. These are not specific. And if your aminosolicitates and steroids are not helping, then we will step up to a whole body immune response. These are anti-rejection meds. They're not low risk meds. If you are on, and sometimes they will have chemotherapy meds, because what we're doing is we're just trying to shut down the immune system to save the bowel. You can imagine that there's going to be a lot of complications from that. You get a high risk of infections. So after you've had a lot of flare-ups, or you've had many complications, or many IV admissions, or many concerns with your Crohn's or ulcerative colitis, then they're like, we got to remove it. There's something in that piece of bowel that is just inviting attack. We're going to remove it. It's not functional anymore. It's scarred. It's useless. It's not absorbing. Let's take it out. There's something in there that's right. So they will remove the disease segments of bowels. So a lot of patients, 60 to 70% of people with Crohn's end up with bowel resections. And 20 to 30% of patients with ulcerative colitis end up with bowel resection. So it happens very, very frequently to many people. It's not the end of the world. We're going to just remove it, and sometimes it fixes people's symptoms. It's up to the patient and the doctor when they decide bowel resection. We can't go anymore. There's no more meds that are working for you. We need to do bowel resection. But once they are resected the bowel, Crohn's may attack another piece of the bowel, and the whole cycle starts again. But bowel, they will try, if they are removing pieces of the bowel, just like removing pieces of the esophagus or pieces of the stomach, they will try to put it back together because a functioning GI tract is important for us. So that's called Re-Anastomosis. I think I put that in there. They anastomose something together. That means they've sutured something together. So they'll cut out the piece of the bowel, and they will put it together and suture it back up. But again, when you've sutured up a piece, we're not going to put a lot of stuff through it and stress those sutures. So they will probably be NPO for a while after intestinal surgery as well. We don't want to stress those sutures. If the bowel was too much to reconnect, then they will end up with an ostomy bag. Some patients end up with a temporary ostomy until things settle down and heal, and then they go back in and try the anastomosis. So if for some reason after they picked up they took this piece of bowel out, and they decide, you know what, those ends just look a little bit too fragile to sew together, what they'll do is they'll divert the bowel out to a bag, to the ostomy, and just let that bowel heal a little bit, and then go back in when it's not so angry and try to re-anastomose it. So some patients, we might want to tell them, hey, if you come out with a bag, they might try to fix it later. But if they took too much bowel and there's no way it's ever going to join up again, then you live with an ostomy bag, okay? And I'm sure when you talked about ostomies, you know that what comes out of an ostomy is just wherever it is in the tract. So if you have a small bowel ostomy, what does your stool look like? What does your stool look like when it hasn't been processed all the way through? It's very watery. It's not brown. It's not stinky. It's just kind of like watery. It's half digested. But that's the best we got. That's where the tract ends. So that's what's coming out. Large bowel ostomies are more fecal looking because that's where the feces are formed, is in the large bowel. Yes?
Do they get nutrition from other sources then if they're not?
Yes, it will depend on, that's a good question. It'll depend on how much the bowel has been removed. And like you said, if it's a high, small bowel ostomy, it never got absorbed, they may need something supplemental. What you can do for supplement, so when you can't digest well, the supplemental feedings, if you've ever seen tube feedings or supplemental feedings, there's so many different categories of them. And kind of like how you gave babies, if you give them formula, there's some formulas that are easier for people to tolerate, they're just more expensive, and then there's the regular formulas. The ones that have everything already broken down for you, that they will give you supplemental feedings that everything's already in its broken down state. And so your body, in your small intestine, is not worried about breakdown as much as it is just absorbing. So they can supplemental feed, and there are different kinds of supplemental feeding, depending on how much bowel you have left. Because the goal is to use the bowel or lose it. It kind of gets weak very quickly. It's a muscle that needs to be used frequently. And so if you never put anything in the bowel will die. So we do want to feed it. We'll just feed it with something appropriate to the length of bowel that they have to avoid malnutrition. They may have to take a lot more supplemental vitamins, minerals, IV injections, things like that to maintain their vitamins. So that is your treatment for these inflammatory bowel diseases. And like I said, there's nothing a patient can really do to prevent getting an inflammatory bowel disease. Just like you can't prevent diabetes, type 1 diabetes. You can't prevent these autoimmune things, but you can reduce the triggers and reduce the flare-ups, because the flare-ups are where this inflammation is growing and causing problems. So you can see if you are eating things that trigger a flare-up. So let's say every time you have dairy, you end up with bloody diarrhea, constipation, and stuff. They're going to say, stop eating dairy. Just stop it. If cheese, what is it? Let me think of a non-dairy thing that's annoying to people. I don't know. No, I can't think right now. But yeah, if there is a food trigger that causes a flare-up, then stop it. You got to stop whatever causes a flare-up. So they're going to be food. You're going to be food diarrheaing. You're going to be diarrheaing. What's diarrheaing? Diary. You keep a diary about what is going on in your life when you're having a flare-up, so that you can identify your triggers for a flare-up. Because when you're having no symptoms or just occasional symptoms, we want to reduce the numbers of flare-ups. The people with more flare-ups end up with the complications, end up with the bowel resections. So if you're going to reduce the number of flare-ups, you might keep your bowel a little healthier. So our education for them, take your GI immunosuppressants, modify your diet, figure out what your triggers are, but a lot of fluid and fiber when you're not in a flare-up. They'll know they're in a flare-up because the pain goes up, the bleeding goes up, the risk of constipation, your cramping goes up because the cramping is really their signal that they're in a flare-up. Their pain gets worse. You're like, oh, well, something's not good in there. Then you look around, what was I eating? What happened? What was going on in my life? What were my triggers? And find them. It's like having a migraine, figuring out what's triggering your migraine. Figure out what's triggering the flare-ups and reduce those. When you are in a flare-up and having a lot of cramping and stuff, low residue diet and water, fluids. Encourage fluids and rest the bowel when they're inflamed. Otherwise, when they're not inflamed, fiber. Okay? And they are managing this based on their pain. And so you're going to be watching their pain too. The triggers are listed here, and there's also a colitis foundation for more information. Okay? So inflammatory bowel disease, take your immunosuppressants and try to avoid flare-ups. Irritable bowel syndrome, IBS, is not an actual disease that damages your intestines. It is a motility nerve disorder. So this is the nerves innervating the gut send weird mixed signals to the gut. Speed up, slow down, speed up, slow down, speed up, slow down, to different parts of the intestine. So it's like lights that aren't synced well on a road. You know, like when you get all those green lights, everything's great. And then you're like, I just got through a green light and it turned red on the next light. Things are just not moving very well down the road. So here things are moving. So one part of the gut is doing fast peristalsis. The other part of the gut is slowing down. It's just bad innervation to the gut. It's linked to anxiety, depression. We don't know. Honestly, this is another one. They don't know. It's linked more to women than to men. So, of course, they put it with the anxiety, depression, and mental health disorders field. Not getting on my soapbox again. But it is more prevalent in women, and so they're thinking there's a hormone component to it. Maybe it's just a stress issue. But it causes crampy abdominal pain because of the increased peristalsis, and you can get diarrhea and mucus-like stools. But you can also have constipation and bloating in areas with low peristalsis. So you can see that the bowel here, it's all working great. This piece of the bowel is like, and it's like, whoa. And then this piece of the bowel, it's slowing down. And it's like, oh my God. So there's start, stops. And so what comes out the other end is a combination, again, of alternating constipation and diarrhea. Because your bowels are just innervated badly. And like I said, they don't really know what's causing it. There's no worsening cues for it. It's an innervation problem, not a processing problem. The bowel wall doesn't change. Nothing's actually being damaged other than your mental health. This is where you're going to watch bowel sounds. There's no bleeding. There's no big issues with it. It's just bad innervation. So they don't really know the cause, but they want to reduce your stress and anxiety. So if you have IBS and you're in nursing school, I apologize. Because probably probiotics, because they don't know if the GI guts are involved. So hey, put some good stuff in there and see if that works. Adequate hydration, that's always good for the gut. Fluids are great for the gut. There's no time, unless your kidneys don't work, that we are going to reduce fluid to the gut, okay? Even unless you are strict NPO, fluids in the gut are great. They squeak by obstructions, they squeak by stuff. Usually fluids are the best thing for the gut. There are a few times when we don't want that, complete obstructions or right after surgery. But most of the time, fluids are just fine. These FODMAP foods are the only thing they can find that seems to be a consistent trigger for people. And I don't even know if it's a trigger. I think it's just because it helps with the gas and bloating that come with IBS. But, you know, they're foods that make you fart. Grains, dairy products, the hard to digest foods. The more hard it is to digest, the more the bowel has to kind of churn to digest stuff and work harder to digest it, causes more gases. Also, the bacteria, when they interact with these things and break it down, cause gas. So try to avoid things that are gassy foods, basically. And it's symptom treatment. Treat your constipation, treat your diarrhea. treat your pain and cramping. The big takeaway from IBS is they don't really know what's causing it, and they think it's a stress-related disorder or a hormone-related disorder causing nerve intervention, but no damage, so no bleeding. There's no bloody output in IBS. If there's bloody output, there's something else going on. Appendicitis, I don't know if we need to spend a lot of time on appendicitis. I think this one's kind of a common sense. It's an infected piece, but I want to show you where it is. It's at the end of it's at the beginning of the colon, the end of the small intestine, at this ileocecal valve. So where the small intestine dumps into the large intestine, there's a little appendage called the appendix. And well, nobody knows what it's for. They think maybe it was when we ate rocks or something. I don't know. Nobody knows what it's for. But it's just an appendage that we don't really need anymore. But it does get stuff. It's kind of right there at the bottom of the large intestine where the small intestine's dumping in there. So when you get sludgy in there, or you're not eating really well, or you're not fibering, and you're not drinking a lot of water, things kind of get stuck in the appendix. And if that area gets inflamed or infected, then you will have pain. You have pain over the right lower quadrant at the McBurney's point. It is a point halfway between, if you feel I can't feel my ischial spine, like the pelvis and your belly button on a diagonal, it's right in the middle. But they just tell you to find that spot on your pelvis where you can feel that pelvic ridge or bump, and it's kind of right next to that, right a little above and to the right of it. But it's called McBurney's point, and when they had the Bernie Sanders meme about the mittens, they had Bernie sitting on top of McBurney's point, which I thought was hilarious. I couldn't find the meme. But it's an infection of the colon, so fever, increased white blood cells, nausea, vomiting, diarrhea. The risk for it is peritonitis, because if your appendix perforates, it's sending that right into your abdominal area. Fun story, I did that. I ruptured my appendix because I'm a nurse, and I'm a bad nurse apparently, and I didn't want to admit there was anything wrong with me. And as I'm carrying baskets up the stairs, and I'm like, whew, that feels like labor pain. You'd think I'd gone, but I had worked the night before, and we had eaten Chinese food from a place that shouldn't be serving Chinese food at 3 a.m. And so I assumed I had food poisoning. And I'm like, God, if I could just throw up, I'd feel better. I'm like, I shouldn't have eaten the Chinese food. And it was my appendix. So when I woke up in the middle of the night, the pain woke me up in the middle of the night, and I went by my little McBurney's point, and I'm like, oh, yeah, okay. I woke up my husband, and I'm like, I got appendicitis. I need to go to the hospital. But, of course, before I went, I arranged daycare for my children. I got my children their breakfast. I got them off to school. I did everything. And I showed up in the ER at 8 in the morning, and when the ER is nice and quiet. And they went in, they did the ultrasound, and they're like, never... That's not a good sign when your ultrasound person goes, It had already ruptured. And what happened when it ruptured is the pain went away. So I'm sitting in the ED, and I'm like, damn, it doesn't hurt anymore. There was nothing wrong with me all along. This is terrible. Turned out it had ruptured. I did lose 4 centimeters of my bowel. Yay me! But it got re-anastomosed, and it was fine. IV antibiotics afterwards, and everything was okay. The moral of the story is if you have pain at McBurney's point, don't wait. Don't send your kids off to school. Don't find them daycare. Go to the hospital and get it treated. Because if it ruptures, you do end up now on what my husband calls my week-long vacation on IV antibiotics, and now open surgery instead of laparoscopic surgery. So don't do that, because then you don't want to tell anyone that you were a nurse. Because how does a nurse miss appendicitis?
And they wonder why I have more IBS.
Yeah, and they wonder. Anyway, it is antibiotics, NPO until surgery, and go to surgery. That's appendicitis, but I do like to throw that story in there. So let's talk about bowel obstruction, and then I will probably have to just do the voiceover for liver pancreas and let you watch that and listen to that at some point. But you feel free to stay while I yap to an empty room if you want. But we will finish after mechanical obstruction, and I'll let you go, and I'll just voice over the rest of it. I talked too long. Anyway, mechanical obstruction versus paralytic ileus. There are 2 kinds of bowel obstruction, mechanical and paralytic ileus. Mechanical just means something in the way. Something's in the way, and we have to remove it. Usually, obstructions need to be moved by surgery. The only obstruction that does not get removed by surgery is severe constipation, but severe constipation is an obstruction and can cause bowel obstruction symptoms. Strangulated hernia, I mean, you don't need to know these. This is more for information and vocabulary in case you get a patient that has a volvus, you'll know what it is. But you're not diagnosing these. They're all diagnosed on CT scan or ultrasound or x-ray. But basically there's a blockage to food getting through the intestine. Yes, you can still have diarrhea with it, even though you have constipation. Here's what we expect to see. We never really like bowel obstructions. They cause a lot of problems. What we expect to see, though, is all the stuff that's happening. And this is kind of a great picture. This is your obstruction, whatever it is. I don't know how you got a boulder in there, but you got an obstruction. What is passing past the obstruction is anything that makes its way around. So yes, diarrhea. Diarrhea can make its way around. Fluids, mucus can make their way around. Mucus is all squishy, make its way around. And gases, they make their way around. So you can still be passing gas. You can still have diarrhea. That is not a sign that you have, that's not definitive for a bowel obstruction. No bowel movement is not definitive for a bowel obstruction. Neither is having a bowel movement a rule out for an obstruction. What is going to be normal or expected and basically diagnostic of a bowel obstruction is hyperactive bowel sounds above the obstruction. Because the bowel is like, let's get this, okay, we'll push harder. We'll push harder. Those little villi are moving everything. Your tube is like contracting real hard to try and get past that obstruction. So what is going to squeak around there is anything liquid. But otherwise, everything's stuck. The higher up in your bowel, the worse the symptoms. So the bowel sounds above the obstruction are going to be hyperactive. Hyperactive means you're hearing them like every 1 or 2 seconds. Or you probably even heard them. Just because you have hyperactive bowel sounds doesn't mean you have an obstruction. They're normal after you eat because you're trying to move things through. But this is hyperactive all the time because you have an obstruction. There's also a great amount of pain, cramping and pain. When you have just loud bowel sounds, you're not having pain too, usually. This is unrelenting pain that usually brings people in. The higher up in the bowel, the worse the pain and the worse the symptoms are. Because the small intestine can't really hold and distend as much as the large colon. So the small bowel has symptoms before, the worst symptoms in the smaller part of the intestine. So small bowel obstructions have worse symptoms. But they have normal or hypoactive bowel sounds below. There's nothing to move through below other than liquid, which is just sliding out. So the bowels are like, I don't got anything to do. The ones downstream are like, oh, no, nothing's coming. I don't have to do anything. So they're not going to be absent. They're just going to be either normal or slow because there's nothing to do. But there's nothing diagnostic about that. It's all the hyperactive bowel sounds. So we got to look for it. If you think your patient has an obstruction, they're cramping, we'll ask them, where is it? And then we're going to follow it with our stethoscope. Is it in the right upper quadrant? All right, let me listen there. Let me look around in the right upper quadrant to see if I hear where those hyperactive bowel sounds are. When you're listening to your quadrants, you are hearing small and large bowel sounds because your small intestines are all over and your colon is draped over the top of the small intestines throughout all of your quadrants. So it doesn't really tell you where the bowel is. You're just going to give them an idea of where to look on the CT scan or something. But like if it's in the right lower quadrant, it could be this ascending colon. It could be part of the small bowel that's underneath there. We're not really sure. But we are listening for where we hear the hyperactive bowel sounds. Because if you hear hyperactive bowel sounds only in one area and they never move, that's where your obstruction is. You could have mucoid diarrhea and, of course, anorexia, nausea, and vomiting, because what is happening behind here? Huge amounts of distension, right? This is causing, get through there. It's like pummeling. And the food's stuck there. And bacteria are still we're still digesting, creating gases, but nothing can move through. So you start distending your bowel in that area. Our abdomen holds so much room. We can bloat and not think a thing of it. We can leak fluid into our abdomen and never notice. But what happens is the pressure gets so high in here that stuff starts oozing across the intestinal wall. Normally only nutrients and stuff cross the intestinal wall to get into the bloodstream. But now we are getting bacteria coming across, fluids coming across. We've got a lot of stuff spilling into our peritoneal space that shouldn't be spilling out of our digestive system. So now it starts getting, that we are getting abdominal distension that starts maybe pressing up on our diaphragm and causing shortness of breath. It's like, I can't even catch my breath. My stomach's so swollen. It may not be out to here. It may not even look that distended. It might just be distended out like an inch or two, but it's enough to press, maybe because we can't see inside and see all the distension that's happening inside. But what we can see on our patient is that it's causing difficulty breathing. That means all that distension is pressing in and irritating the diaphragm. So when your abdominal distension causes shortness of breath, it can cause sepsis because we got bacteria crossing the cell wall, the thin membrane there that's getting thinned out by all that stretch. We've got electrolytes coming across that wall. We've got fluids coming across that wall. You can actually have the intestine rupture if it blows up so much. It can only give so much. It's not a stomach. It's just a tube. The small bowel does not distend very well at all. So if you had a tube that started distending and it couldn't take any more, I don't have a drawing. Let me make a drawing. Whiteboard. Okay, so let's draw this is a normal intestine. Right? Now we got a little blockage here. So what is happening to the bowel wall after you get a blockage? It starts to distend, right? This area starts to distend. Now, you have a lot of intestine behind you. So where is the distension going to go? Is this going to keep growing out this way? Or is it going to extend back this way? It's going to extend back. So the distension starts growing. The only way that you would create a rupture is that if you have created distension, so we're starting this distension, we've said the distension is going to go all the way back through the whole intestine. Because pressure is not going to build, it's going to move backwards, right? So now this whole thing starts to distend. But if you've distended your whole intestine and it's like no more room in the end, then this area starts distending even more and trying to send it this way. And then eventually you'll end up getting kind of narrower. But this is why it's worse higher up in the bowel. There's not as much bowel behind it to take that distension. So if it's high up in the small bowel, like if it's in the duodenum or the jejunum, way up high in the small bowel, if that's where your obstruction is, there's not as much mileage of bowel to take the distension away. Where's that distension going to back up into? Well, it's going to back up through the diaphragm, through the stomach, and then distend the stomach, and then start causing. So if it's causing shortness of breath, we've distended way back into the stomach, okay? That's not good. What's going to happen if we keep distending and there's no room? You're going to vomit up whatever's in your intestine because that is all backed up. And so if you're starting to have abdominal pain, cramping, and distension to the point of shortness of breath, that's really a sign that your intestines have distended all the way back into the stomach. And you're probably going to end up vomiting something. This is where people vomit up intestinal contents because they have a bowel obstruction. Large bowel. So if you have an obstruction in the large bowel, you've got like a mile or two of small intestine to take the distension. And so it takes a little bit more before you start seeing like the wild symptoms of the worsening small bowel obstruction. So the worsening cues are that abdominal stenting causes shortness of breath, because now that's a sign that we've distended all the way through to the stomach. The stomach's big, and it's starting to press up on that diaphragm. Sepsis is, of course, like I said, infection, electrolyte imbalance, peritonitis, and intestinal rupture. So we got to get the obstruction out of there. We're going to be listening to those bowel sounds, trying to find the location, sending them to their abdominal x-ray, CT scan, ultrasounds, because that's going to help find the location. Abdominal girth measurement, that will tell us the distension, right? You measure it with an actual measuring tape. Because if we're watching them over the next hour or two to see how bad things are growing, we're going to want to keep a close eye on that distension because that's happening. Or just telling to see if you have distension, measure it, check it again an hour later to see if your stomach's distended further out. Okay? Because even like an inch of distension can be a big change in your bowel. So we might want to check that abdominal girth measurement, pain location, stool frequency, quality. It's probably going to be diarrhea. But if it's not a full-on occlusion, you might still have some stool passing through. Check the quality of your bowel, but basically the definitive diagnosis is getting them over to their abdominal x-ray, CT scan, and ultrasound. If you think your patient has a small bowel obstruction or a bowel obstruction, send them to their test if you can. Get them, call the thing and say, give me my test. I think this patient has a small bowel obstruction. They do prioritize the patients with a small bowel obstruction for these exams because they know the risk of it rupturing or causing other problems is pretty high, so they try to get them into these exams pretty quickly. When the exam comes back and says it's constipation, well, that's when you get to have some fun, because we're going to put no more food in the mouth, because any small bowel obstruction, no more, okay, you're done until we clear the obstruction. No more food. NPO for any patient with a small bowel obstruction. Enemas, laxatives, we're going to hit it from the top and the bottom and try to get it out. IV fluids. IV fluids are always indicated for GI patients. Always, always, always. IV fluids, because fluids are the best way to get stuff through. And also in a small bowel obstruction or any bowel surgery, when you damage the bowel or you're distending the bowel, stuff translocates across, including fluids and electrolytes and stuff, so we do want to replace fluids. One of the nursing things that I've always heard is that GI patients need fluids. GI patients always need fluids. Whenever there's something wrong with the gut, fluid translocates into your abdomen. You end up with distended abdomen, but you need to replace the fluids that have been lost out of the gut. So most patients with GI stuff gets IV fluids. If it's not constipation, if it's any of the other mechanical obstructions, IV fluids, because IV fluids are important. Antibiotics, because we've probably got bacteria translocating across, so we're going to prevent that. Surgery, and until surgery, they have an NPO. They will probably also get an NG tube. And why do we want to put an NG tube in them? What's happening in their gut? It's distending, right? And making its way back. So what are we doing with the NG tube? We're going to put it to suction. So it's going to be abdominal decompression. We're basically, the only thing we can access with that tube is the stomach. So we're going to put a tube in the stomach and we're going to put it to suction. What's the suction going to pull out? Anything in the stomach and any gases from below the stomach, okay? It's just going to help pull that distension back so it doesn't keep distending and explode anything. So gastric decompression is appropriate in a small bowel obstruction because it's going to expand. We're just trying to prevent it from, we're trying to remove the gas from the situation, basically. And we can pull it out of the stomach. And the pyloric sphincter stays open unless the duodenum has shut it. So when we put that tube in there, it pulls from the intestine too. We're going to pull the gas and stuff out of the system to relieve the distension until they go to surgery. But this treatment for bowel obstruction is a surgery unless it's constipation. Paralytic ileus is where the bowel just stops. It causes massively severe, like you can see it on an x-ray. This is just an x-ray. Look at these bowels. This is not your large bowel. Your large bowel is here, here, and here. That is your small bowel. That is a really big small bowel. And that small bowel cannot handle that. That is probably working all its way back up to the stomach, okay? This patient is a high risk. I would not be surprised if they vomited up fecal matter, because look at that. That's huge. Severe abdominal distension. This is where we said absent bowel sounds. I already had my soapbox on bowel sounds. Do not chart absent bowel sounds unless you've heard nothing for 2 minutes. And that you can have absent in one quadrant and maybe it's starting to move in another. Listen to all 4 quadrants until you hear 1 or 2 bowel sounds, because you need to hear 2 to time them, right? Okay, that's great. When's the next whoop? And that will tell you normal, hyperactive, hypoactive, or absent. If you never hear a single bowel sound in 2 minutes, that's absent. But if you hear 1 and then maybe a minute later another, hypoactive. If you hear 1 and then 1 second later another, hyperactive. Or 1 and then another right after, hyperactive. If you got every minute or less is probably normal. You can have, there's nothing in there. You're not going to hear peristalsis because there's nothing in there. It might take a minute to hear your next one, but it's not going to take 2 minutes, okay? So I usually say if I'm listening to something for the second growl, if I'm listening about a minute, I'm like, I'm tired. Hypoactive. If I hear that second one in like 30 seconds or so, I'm like, that's normal. In a minute, I'm like, that's kind of slow. In 2 minutes, that's absent. Okay? That's kind of subjective, but I'm sure someone can probably find something on the timing of normal, slow, and fast. But you have to have no bowel sounds in that quadrant for 2 minutes to call them absent. There's nothing going on. Everything's there. There's no bowel moves, nothing. No diarrhea, nothing, because the whole thing is dead and paralyzed. This happens after, but if it distends out, peritonitis, rupture, sepsis, electrolyte imbalance are your worsening conditions. How do you think we treat it? It's paralyzed. What are we going to do? I'm going to see if you don't go forward. What would you like to do? How would you get this going? Fine, I'll tell you. Gut motility stimulators. They do have ones that will help your gut work a little better. Narcotics are the big risk factors, I think I put them in, I always like to put them in the thing, the causes. Does it say what for paralytic ileus? I didn't put the cause for paralytic ileus. The causes for paralytic ileus, just scribble those in there, and I will refix this again. The causes for paralytic ileus are usually massive sepsis, like being super severely ill, like high levels of trauma, high levels of sepsis. Abdominal surgery, whenever you go in there and anesthetize the bowel, they take a long time to wake up. And especially if we manipulated them and goofed around with them and stuff, they're like, nah, I'm gonna rest for a while. I'm not gonna wake up. So abdominal surgery is a big risk for paralytic ileus. Anesthesia is a risk for paralytic ileus. So really any anesthesia. So I would say sepsis, trauma, abdominal surgery, or any kind of real big, heavy general anesthesia is a risk for paralytic ileus. And what's the last one I can think of? Narcotics. Narcotics slow you down. They cause constipation, right? Narcotics can also slow it down to nothing. So if they're overdosing on narcotics, they might end up with a paralytic ileus. So what we're going to do, no more. If it's paralyzed, why would we put anything in there, right? Let's just not add more fuel to the fire. NPO, NG tube for decompression. I want to decompress that. Look at the stomach. Look at the stomach. Dude, it's not even like a stomach. It's a ball. Please get the gas out of that system. Put an NG tube there. Hook it up to suction. You will relieve that pressure. That thing's about to pop. Okay? And popping is not good. So NG tube to decompress. Gut motility stimulators to get things going. The biggest one is metoclopramide or Reglan. You might see patients post-op on Reglan. That's because they had such heavy levels of anesthesia. They know they might be prone to this, so they put them on Reglan to move them forward. Relistor or methanol, whatever. This one's really good for, they give that concurrent with high narcotic use because it combats the narcotic effect on the bowel. So the methylnaltrexone, I don't know, kind of looks like naloxone to me, and I convert, naloxone with it looks kind of like it's got those oxones. So that's how I remember it, is anything with oxone is against or helping us deal with narcotics. Relistor, so this oxone, this counteracts the effect of the narcotics on the bowels. It prevents constipation and prevents paralytic ileus. So you may see this one given on a scheduled basis if the patient's on high levels of narcotics. Yes?
So they just have bowel surgery, so they want narcotics.
Yes.
So you just say...
They will probably, it will depend on the doses of the narcotics. This is for high dose, but it's going to immune the intestine to the effects of the narcotic.
Okay, and then the next one says decrease any narcotic.
Well, you would try to decrease the narcotic use, so lower the dose. It's not saying take it away, it's just trying to reduce it. So if your patient's taking it every hour, you either need to find something that's working better, or they will pair this oxone with it to basically, all right, we can't get away from the high doses of narcotics, but we can at least immune the gut to it. So you see these given together, this one usually given with a narcotic. That's to immune the gut to it. Antibiotics, because anytime we have a swollen bowel, we got a risk of an infection, and IV fluids, because every GI patient gets IV fluids. All right. And you can add the causes for or look them up in your book. I didn't put them in the slide. It doesn't mean you don't need to know them. Put them in your book. Just most GI patients, especially with distension, NPO. If the GI system is not working appropriately, stop putting stuff in there. Okay? NPO, especially if distension's involved. With Crohn's disease and inflammatory, there's still peristalsis. It's just not good. We can keep fluids or whatever. But if it has stopped, if you are obstructed or paralytic, don't give them food. If you suspect obstruction or paralysis, just from maybe, I don't know, I think, they're complaining of massive abdominal cramping pain. They've got no history of Crohn's, colitis. They've got massive cramping, abdominal pain. They haven't had a bowel movement, or their only bowel movement is liquid and mucoid or bloody. Okay, you know what? We're going to stop fluids. We're going to stop NPO. You don't have to have the order to tell your patient, you know what, until we get further workup or until I talk to your doctor, I don't want to put more food in there. It's a very good intervention for patients that are having inflammation and cramping. Let's not add more to the fire. Once you have a diagnosis, you can kind of go from there. But until you're waiting, if your patient's complaining and you're putting in a call to the doc and they're like, can I have some water? No. Just let us figure out what's going on first. Let me talk to your doctor. But NPO is appropriate for a lot of bowel things because we don't want to add more fuel to the fire. If you are going to feed them and you don't have any orders and you're waiting for the doctor to call back and they're really, really thirsty, what would you give them? Ice chips or some kind of liquid, clear liquid. Don't add more. And then, if the doc's being unclear or not sure, if you do have to choose a food source, make it low residue. Make it something not fibrous. But I would stick with a liquid diet or a clear liquid diet on patients until I clarify with the doctor what's going on. Once you have a diagnosis, you've got more ideas of what's going on. Colonoscopy, you can read about colonoscopy. The biggest risk of a colonoscopy is that camera hitting something and perforating that bowel or causing bleeding. We'll let you read through that. I think we're getting towards the end. Intestinal surgery, this is going to be very similar to gastric surgery. We don't have dumping syndrome with intestinal surgery usually, unless it's surgery on the duodenum itself. This is lower down, and so we're not going to have the dumping syndrome because the control from the stomach to the duodenum, we've already dealt with that. So everything other than the no dumping syndrome with intestinal surgery, but the same issues, but also with intestinal surgery, you have a higher risk of paralytic ileus. Gastric surgery, we're not really messing with the intestines. You might have it from the anesthesia from your gastric surgery, but they usually do Reglan or metoclopramide on a lot of patients with anesthesia. So, GI tubes, I'm going to let you just look through this. There might be a couple questions on the care of the patient with the tube. So this is just information about it. If you hear words like sumps or Dobhoffs or small feeding tubes, we did it in lab, but this is, again, I never tested you in lab, but here's where a test question might come up about feeding tubes. So I'd like you to know kind of what a small bowel feeding tube, what's appropriate for it. The big thing is which one can be hooked up to suction. What do you think? The one with the vent can be hooked up to suction. If we hook these up to suction, and I will bring these to class next week so we can play with them more, it's going to suction, but these are also very narrow. They may collapse. They're very soft. I'll pass them around, let you play with them next week. This one's very, very soft and just would collapse. If you put it to suction, it just collapses up. The other thing is that if you are suctioning out, you're going to cause a deflation, right? If I put a big a suction catheter into a balloon and sucked the air out of the balloon, what's going to happen to the balloon? It's going to close up and deflate all around the tube. The vent is to bring air in so that as stuff leaves, air gets back in, just to keep it inflated so that the stomach, because you're putting this tube into the stomach, we also don't suction straight out of the small bowel. We're going to suction out of the stomach because the stomach is a big bag. But we can put vent air into the stomach so that as stuff comes out of the stomach, the vent pulls air in so that the same amount of air kind of stays in there. And it's just to keep the stomach from being damaged. I will bring my balloon next week and hook it up to suction so you can see. But when you put, or if I have my suction, I'll bring it. We put a plastic bag around it and you'll see that bag just suction up. You'll actually suction stomach cells into the suction catheter because the stomach will collapse around the suction catheter and get sucked up into it. So the stomach cells, you'll damage your stomach. So the vent is needed to put air back into the stomach to keep it inflated while the suction is pulling out. I'll do that demo next week. But really, the one with the vent is the only one that you can suction for. It's also the only one wide enough to pull out any junk from your stomach. The other two would get blocked very easily. They're just for feeding only. We also have the pictures of the tubes. You probably did these in block 1, I'm hoping, maybe not. But if not, now you can kind of know what a G tube is, a PEG tube, a GJ tube, pictures of where everything is. GJ tubes there's a section that stops in the stomach, and then there's another section that goes into the jejunum. So it passes the whole duodenum and feeds into the jejunum. So this is a great choice for someone that might need some suctioning, because you would suction the gastric side and feed the bowel side. So I'll bring these all to class next week and kind of show you how we hook them all up and how they work and stuff like that. This is just for your knowledge, because we're not putting them in, except we would put these in, and we may decide based on our patient which one to put in. They're going to say just drop a feeding tube. Which one do you pick? If you think you're going to have to suction your patient, you pick the sump. If you don't think you're going to have to suction your patient, you think you're just going to be feeding your patient, then a small bowel tube is appropriate. If you also need to bypass the duodenum because you've had dumping syndrome, then a small bowel feeding tube threaded into the jejunum is a good choice. We've bypassed the duodenum and we're dumping food past the duodenum. So there is lots of choices, and we'll talk a little bit more about those next week. Yes?
Do they go in just like
Anything like this is going to go in like an NG tube. You just put it down the thing. It's just that the length is going to be longer. If you're dropping something in the jejunum, you're going to measure, to your ear, down, but you're not going to stop here because you don't want it in the stomach. You want it in the jejunum. You're going to give it a little bit longer.
And then they have to go get an x-ray?
They all have to have x-rays after to confirm placement. Yes, because you want, especially the small bowel ones, a lot of times you'll get them right into the stomach. They have weighted tubes on them so that the peristalsis can take them. You might have to wait a couple of hours for them to move to the right place. Because if the pyloric sphincter is closed, you're not going to get past the stomach anyway, but the peristalsis will take it further in. So they won't let you feed through it until it's in the proper place. And then the J tubes are put in either in interventional radiology or by a surgeon. This is just in case you wanted a reference on how to put them in. I'm not going to test you on how to put it in. And here's what I would probably test you on. Is what do you expect and what do you not expect. That's usually what I put my test questions on if it's a procedure or if it's a something. We do want things hooked up to suction. We expect suction to the stomach to be no more than 120. We don't want full suction on the stomach. We want low suction. Most drainage from the stomach or the intestines is green or brown. And we do want to make sure that if you are suctioning, you have a sump. And if it's feeding, that it flushes. And we will measure residuals in the stomach. Which means, what does it mean if you're putting in 30 milliliters an hour of tube feeding and you're pulling, let's say after 4 hours, 200 milliliters out of your stomach?
Not moving.
Nothing's moving. It's a big clue that you're not tolerating your tube feeding. So we do like to pull residuals if it's in the stomach. In the intestines, we don't usually pull residuals because the tube will collapse if we try to pull suction from the stomach, from the intestine on those small little feeding tubes. We can't really check residual. And it's also in the intestines, so we're like, hopefully it worked. But if it's in the stomach, we can do residual feeding. But if you dump it into the jejunum and it's not moving, where's it going to end up? So if you dump it into the jejunum and it just sits there, where's it going to leak back to? It's going to move back up, and if you keep loading it in, 30 milliliters an hour, eventually it will get back up in the stomach. So checking residuals is always kind of a good idea if you have access to just see if your tube feeding is being tolerated, if it's moving. This is just kind of if they're feeding them, sitting them upright during feedings. Your patient can still aspirate, meaning they can inhale their tube feedings if it's not tolerated. So let's say we're putting it at 30 milliliters an hour into their stomach, but it's not moving. So now their stomach's getting bigger and bigger and bigger and bigger with tube feeding. If you're laying flat on your back and they go, where is it going? If you vomit it up, it's going right down your trachea into your lungs, and now you have an aspiration pneumonia. So sit your patient up during feedings in case it if you're not tolerating the tube feeding and it's not moving and you do vomit it up, it's not going down your airway. Flush with water every 4 to 6 hours. Most patients on tube feeding is very thick and hypertonic. And so we want to kind of thin that out with some water. Most patients have a prescribed amount of free water. Free water is water just from the sink. Okay, it's just free water. But we need to make sure that tube feeding does not have a lot of water in it. It's liquidy, but it's not full of water. And so we do need to make sure that they are being hydrated as well, either with IV or prescribed water. Make sure it's taped, blah, blah, blah. Stuff from the lab. But this is where I would probably have 1 or 2 questions on G-tubes. So it would probably more be about what you expect and what you don't expect.